Hi everyone, a very good evening to each one of you. Myself, Dr. Vaibhav Jain, and we will be doing a quick and rapid revision of physiology here. Right, we will be focusing specifically on the important things which can be asked in your examination, all the important topics. Right, we will be discussing about them. So please let me know whether my audio and video is clear so that we can proceed with the session. You can see me and hear me well. All right. So the first thing before starting it off, the first thing that we are having the code. Okay, what is the code that we are having? You might be at any state of like you might be at any stage at this particular point of time, but trust me, ultimately every one of you is going to go to this particular state. That means you will be doing this examination. You have to have this thing in your mind that definitely all of you will be clearing the fence definitely one day, right? Now it depends where you are and how to boost, right? For example, you might be in this particular phase. I'll try to do it, right? Don't just try to do it, just tell yourself that I can do it and I will do it. And if you start telling yourself that I can do it and I will do it, you will do it any which ways, right? I've told you earlier also, your brain cannot differentiate between what is right, what is wrong, what is truth, what is false, right? Your brain cannot identify, right? Your brain can only understand what you can tell your body, right? So you can just tell yourself the positive thoughts at this particular point of time and this thing is going to get happened, right? So without any further delay, let's get started, guys. Okay. All right. So what is the neurotransmitter that is released from parasympathetic nervous system? I'm going to take it as in the question answer format, and I would be making you understand the things which are going to come across it, right? Important things which are going to come across it, we will be discussing, you know. Now, since it is the last phase of your examination, I expect good answers from all of you, right? What is the neurotransmitter that is released from the parasympathetic nervous system? Across it, we will be discussing. All right. So the neurotransmitter that is coming from the parasympathetic nervous system. Before that, I want to make you understand what is this parasympathetic nervous system, what is this sympathetic nervous system, right? You will be answering me as fast as possible, right? So we have got two types of nervous system. We have got parasympathetic nervous system. We have got parasympathetic nervous system. Second one is sympathetic nervous system that we have got, right? Some of you are also having difficulties in pharmacology. I know about that, right? So we will try to integrate that thing also, right? Because some of you have messaged me about that, right? So we will try to integrate that thing also, right? So we have got parasympathetic, we have got sympathetic nervous system. What are the neurotransmitter for this parasympathetic nervous system? This is going to be very good. This is going to be acetylcholine. What is the neurotransmitter for sympathetic nervous system? This is going to be your epinephrine, norepinephrine and dopamine. These are all collectively known as catecholamines. इन सबको एक साथ क्या कहा जाता है? Catecholamines कहा जाता है, right? I would be sharing the PDF in the end, है ना? PDF लास्ट में सब मिल जाएगा. Don't worry about that, right? You just focus on the class. Just try to learn the things. Whatever you know, try to answer. Whatever you don't know, just try to learn it here, है ना? I don't want to waste your time, right? Just be with me. Okay, so we have got what? We have got acetylcholine. We have got what? Epinephrine, norepinephrine, dopamine, right? What are the receptors for parasympathetic nervous system? These are going to be your muscarinic receptor. These are going to be your nicotinic receptor. Nicotinic mein we have discussed neuronal. We have discussed about the neuromuscular, right? Neuromuscular is going to be there, right? Then we have got what? Muscarinic receptors are going to be of 5 important types. These are going to be your M1. We have got what? M3. We have got M5. We have got M2. We have got M4. These are the 5 receptors that we are having. 1, 3, 5, 2 and 4, right? This one is going to be present where? In your CNS and in your GIT. It will be present in your CNS and in your GIT. M3 is going to be present where? Let's begin with the body itself. We are discussing normal functioning. We have eyes, so it will be present in the pupil. right? Then it is present in your salivary gland. You will be having which gland? Salivary gland. Then it will be present where? After salivary gland, you will be having what? Bronchus. It will be present in your bronchus, beta. After bronchus, it will be present in your GIT. In your GIT for the movement, right? You will be having bowel. You will be having bladder movements. These are the location of receptors because they will be asking you questions based on them, right? M5 is going to be present in your CNS and M2 is going to be present at two places in your heart. What are those two places? Anyone try to answer? We have got what? Two places, SA node and AV node. SA node and AV node. These are the two important places we have got. These are going to be the places, right? And M4 is going to be present in the CNS also, right? So these are the 5 receptors we are having. One thing we already know, M1, M3 and M5, all of them are going to be GQ type of subunit. And GQ we already know it is going to cause what? Contraction. It is going to cause what? Contraction. And M2 is going to be and M4 is going to be GI inhibitory or G0 type of subunit. It is going to produce what? Relaxation. It is going to produce what? Relaxation. So what is going to happen in this particular patient? Any case, like you talk about organophosphate poisoning, you talk about cigarettes, you talk about anything which is parasympathetic in nature, what is going to happen? Anything which is increasing the acetylcholine, what is going to happen? If you talk about cigarettes, if you talk about organophosphate poisoning, everything is going to do what? In CNS, what is going to happen? Contraction. If there is CNS contraction, beta, अगर CNS आपका contract हो गया, it is going to increase what? Cognition. It is going to increase the brain power, cognition, right? Filtration will be increased. In GIT, it is responsible for the acid release, right? It is going to increase the acid, and that is the reason why we are having what? Cigarette smoking people. Let's try to understand. When you are smoking, what is happening in your body? The same thing will happen here, right? So when you are smoking, what is going to happen? Your cognition will be increased. You will think about things better, right? Second thing, you will be having what? Increase in the acid. नींद आएगी तो cigarette पीते लोग, right? Second thing, you will be having increase in acid, and this acid is going to cause what? This is going to cause what? Acidity. It is going to cause what? Ulcers, right? In pupil, beta, in pupil, you will be having contraction of the pupil. Contraction of the pupil will also known as, what will happen in the pupil? Meiosis will be there in the pupil. Meiosis will be there in the pupil. In salivary gland, you will be having contraction of salivary gland. You will be having what? Increase in salivation. All these things we will be using, right? In bronchus, what is going to happen? Bronchus is going to get constricted. You will be having what? Bronchoconstriction will be there, beta. Bronchoconstriction will be there. In GIT, what is going to happen? You will be having an increase in the movement. Increase in which movement? Increase in peristalsis. Increase in peristalsis will be there, right? Bowel and bladder, what is going to happen in the bowel? Bowel will be increase in the movement. You will be having what? Increase in the movement will lead to increase in diarrhea like situation. Okay, it can cause what? Diarrhea. And bladder, if the bladder is going to get contracted, you will be having what? You will be having urination. You can also call it micturition. So you can have micturition, right? So when you smoke, these are the same things which are going to happen to you. What are the things we are going to have? We have increase in the cognition, we have increase in the acid production leading to ulcer, we have got meiosis, we have got salivation, more salivation. These people are spitting out and there, here and there, right? We have got bronchoconstriction, bronchus can got constricted. You will be having increase in the peristaltic movement. They can have diarrhea or passage of movement. They can have what? Contraction of the urinary bladder leading to what? Micturition. Leading to what? Micturition. M2 is going to be present at two places. You will be having SA node, you will be having AV node. What is going to happen here? These are going to be inhibitory subunits. So they are going to contract or inhibit? They are going to inhibit. So what is going to happen? You will be having decrease in SA node means decrease in heart rate, which are decrease in heart rate. Decrease in AV node means decrease in conduction. Decrease in heart rate, decrease in conduction. Decrease in conduction will be there, right? Decrease in conduction is also known as, this is also known as AV block. We can have what, Bucha? We can have AV block, atrioventricular block. We can also have heart block. We can also have heart block, है ना? Heart block हो जाएगा इस patient का. right? And CNS are not going to be too much important. These are going to be normal, right? So this is going to be the funda when you are having organophosphate poisoning. They can ask you question on organophosphate poisoning. What is the question? They will be asking you what happens in OPC poisoning patient. You remember these things, you remember the symptoms, right? What is going to happen to organophosphate poisoning? The CNS will be having increase in cognition. Acid production will be more. You cannot check for these two things, but you can check for meiosis. So what examiner will write you, if they write you pinpoint pupil, okay, pinpoint pupil, if they write you pinpoint pupil, you will think about which kind of poisoning? You will think about this OPC, this OPC poisoning, which is a type of parasympathetic poisoning, which is a type of parasympathetic poisoning. You can also call it, because the neurotransmitter is acetylcholine, you can also call it bacha cholinergic poisoning. इसका दूसरा नाम cholinergic poisoning, right? So this thing can happen. Then we can have what bronchoconstriction will be there. You can have what increase in peristalsis. That is why these people will take what cigarettes in the morning, right? An increase in peristalsis and organophosphate poisoning will lead to what? Dirty clothes. You can identify the stool will be there, the diarrhea will be there, or the urination will be there. So how you will identify this patient? Patient will be having pinpoint pupil, patient will be having increase in peristalsis, diarrhea and urination will be there, right? What happens to the heart? You will be having decrease in heart rate, decrease in conduction, leading to the death of the patient. Decrease in heart rate is also considered as, this is also known as bradycardia. Another question they will be asking you, bradycardia with AV block. What is the drug of choice for bradycardia with AV block? What would you like to give to this patient? This is going to be your cholinergic thing, cholinergic. Opposite to that is going to be what? Opposite to that is going to be anticholinergic. Opposite to that is going to be anticholinergic. जो भी इसके अपोजिट काम करेगा उसको क्या बोलेंगे? एंटीकोलिनर्जिक बोलेंगे, राइट? सो व्हाट आर द रिसेप्टर? रिसेप्टर रिमेन्स द सेम इन द बॉडी. वंस a receptor is there, that means it will be same throughout the body. But what is going to change? Opposite will be the function. What is going to be the opposite function? What anticholinergic like dhatura poisoning, atropine poisoning, or belladonna poisoning is going to do better? Dhatura, atropine, belladonna poisoning is going to do. Let's try to understand. It is going to increase the cognition or decrease the cognition? It is going to decrease the cognition. You are not in your senses. You are not going to understand. अगर कोई आपको धतूरा खिलाता है, what is the fatal dose for dhatura? Another question, what is the fatal dose? What is the fatal dose for dhatura? How many seeds are the fatal dose, right? So अगर आपको किसी ने धतूरा खिलाया, if someone has given you dhatura, what is going to happen? You will be having decrease in cognition. Cognition कम हो जाएगा. दूसरा क्या होगा? Acid production कम हो जाएगा कि ज़्यादा हो जाएगा? कम हो जाएगा, right? What will happen to the meiosis mydriasis component? Here you will be having mydriasis beta. Pupil will be dilated. Pupil will be dilated. What about the salivation? Decrease in salivation will be there. What happens with the bronchoconstriction? Here you will be having bronchodilation. What happens with the peristalsis? Decrease in peristalsis. इसकी वजह से क्या हो जाएगा? Constipation can be there. This patient might have constipation. What is diarrhea? What is constipation? Urination ज़्यादा होगा, urination कम होगा. Here there will be decrease in maturation. Decrease in the maturation. Decrease in the maturation. Right, very good. This is going to be the thing. More than 100 seeds are going to be the fatal dose for this dhatura. This dhatura is also known as thorn apple. This dhatura is also known as thorn apple. Thorn apple है ना, thorn apple भी बोलते हैं इसको dhatura को. Right. So this is going to be the maturation we can have. We can have constipation. We can have diarrhea, we can have all these things can be there, right? This is going to be the basics about the anticholinergic poisoning. So अगर कोई organophosphate poisoning का drug of choice पूछे, what is going to be your answer? Organophosphate, the person is dying because of decrease in heart rate, decrease in conduction. So this particular thing is going to cause what? It is going to increase the heart rate. ये opposite काम करेगा because this is anticholinergic. It is going to increase the heart rate. It is going to increase the conduction. It is going to increase the heart rate. It is going to increase the conduction also, right? So what is the drug of choice for organophosphate poisoning? Your answer will be this particular one. This is going to be the drug of choice for atropine. Atropine is going to be the drug of choice, right? Atropine is coming under this particular class. Atropine, belladonna or dhatura, they are going to be the good one for organophosphate poisoning, right? This is about the Basics. They can utilize multiple drugs. They will be asking you multiple questions on the drugs. You just need to revise the drugs. This is the basics of this particular system, है ना. ये इसका normal physiology है, ये basics है, right? They will be asking you if someone, in some patient, I want to do what, mydriasis, some kind of drugs I can use. You can use atropine, you can use these drugs which are going to cause what, mydriasis. आपको pupil check करना है. You need to look inside the eye, right? What you will be doing, you will be putting some drops. If someone is having more of acid, you can give M1 blocker. You can give M1 blocker. These are going to be what? These are going to be your telenzepine or pirenzepine group of drugs. And we don't use them commonly. These are going to be your telenzepine, pirenzepine group of drugs. Second thing, if you want to decrease the cognition, you can use drugs which are going to be like truth serum. What is this truth serum? We have got scopolamine. We have got thiopentone. We have got scopolamine. We have got thiopentone. This is going to be truth serum, right? If someone is having increase or decrease in salivation, you can give a cholinergic drug. Okay, what is the drug of choice for Sitka syndrome or Sjogren syndrome? Drug of choice for Sitka syndrome, Sjogren syndrome, or dry mouth xerostomia. This is going to be your cevimeline, which is a cholinergic type of drug. Right? This is going to be cholinergic. If you want to intubate someone, all these things are question, previous year question. If you want to intubate someone, what can happen? This person can do what? Aspiration. So to stop the aspiration, you can give what? Sodium glycopyrrolate, right? This is going to be glycopyrrolate, you can remember. Pyrrolate, which is a pre-anesthetic medication to decrease the secretions. You can use this one to decrease the secretions, right? If someone is having what? Someone is having constipation. If someone is having constipation, what you can do? Someone is having constipation, you can increase this particular thing. If someone is having diarrhea, you can give anticholinergic drugs. What are the anticholinergic drugs you can give in the diarrhea? Someone is having more spasm, more movement, more peristalsis, leading to what? More pain. You can give drugs like dicyclomine, right? This is the anticholinergic drug, right? So these are the drugs that you will be utilizing. आप जितनी भी दवाइयाँ हैं इसके साथ में पढ़ लेना. It will be easy to remember. If someone is having increase in micturition, you can give what? Overactive bladder है किसी को, overactive bladder है, you can give anticholinergic which will lead to decrease in the micturition. बार बार सूसू आता है, you can give what? Anticholinergic. It is going to decrease in the micturition, right? So these are the drugs we are having. This is about the first part. This is about the first part about the parasympathetic nervous system, right? You guys are understanding? All right. Second part we have got is about the sympathetic nervous system. Sympathetic nervous system has got what? It has got certain receptors like alpha 1, we have got alpha 2, we have got beta 1, we have got beta 2, we have got beta 3, right? This alpha 1 is responsible for the vasoconstriction in the blood vessel. It is going to cause vasoconstriction leading to increase in the BP, which is going to increase the BP, right? Second thing, in prostatic urethra, it is going to cause what? It is going to cause contraction, okay? And in pupil, it is going to cause what? It is again going to cause contraction, but for the radial muscle, leading to what? Leading to mydriasis. These functions, you can revise these functions. Alpha 2 will be acting as a brake, okay? Beta 1 is present at two places. One is in your heart, another one is in your kidney. In your heart, you have got what? SA node, you have got AV node, you have got muscles, right? So SA node will be increased, you will be having increase in the heart rate. AV node will be increased, you will be having increase in the conduction. Muscle will be increased, you will be having increase in the contraction will be there. Muscle contraction will be there. Second, it will be present in the kidney. In the kidney, it will be releasing what? Renin. It will be increasing the release of renin, and renin is responsible for what? Activation of RAS system, and RAS system is going to do two important things. One, it is going to increase what? Vasoconstriction, leading to increase in the BP. Second thing, this is going to increase your aldosterone, and this aldosterone is responsible for sodium and water retention. Remember, sodium and water retention, all these things we have discussed in detail, right? Sodium and water retention will be there, and sodium and water retention will automatically lead to what? Increase in the BP again. So this renin is responsible for increase in the BP, right? Then beta 2, we are having this beta 2 is going to cause what? In the smooth muscle, it is going to do what? Bronchodilation. In the bronchus, it is going to do what? Bronchodilation. What about other parts from the bronchus? This is going to cause what? Apart from bronchus, this is also going to cause in the skeletal muscle. In the skeletal muscle, it is going to do contraction, leading to what? Leading to tremors. And in the cardiac muscle, it is going to do cause what? It is going to cause what, Pacha? Palpitation. It is going to cause what? Palpitations in the cardiac muscle. So it is going to cause palpitations in the cardiac muscle, tremors in the skeletal muscle. And this is the question they have asked you from the like another subject. They have asked you beta 2 agonist has got some side effect, like salbutamol has got some side effect. What are the side effect of this salbutamol? Salbutamol has got some side effect. These are the tremors and palpitation. Simple understanding, right? Tremors and palpitation is going to be your answer. Then we have got beta 3. Beta 3 is going to activate your hormone sensitive lipase, leading to what? Lipolysis. One drug you can use, this is going to be your mirabegron, right? This is what is the short summary of alpha sympathetic nervous system, right? Where you can use this nervous system to increase the BP. Like for example, cardiac arrest. What is going to be the drug of choice in the cases of cardiac arrest? Drug of choice for cardiac arrest is going to be what, Bache? Drug of choice for cardiac arrest means complete stoppage of the heart. You can give CPR, and the drug of choice is going to be adrenaline, which is going to work on all the receptor alpha 1, alpha 2, beta 1, beta 2, beta 3. Drug of choice for hypovolemic shock. Remember, for anaphylactic shock also, the drug of choice is going to be what? This is going to be adrenaline. This is going to be adrenaline. A for adrenaline, it will work on all receptor alpha 1, alpha 2, beta 1, beta 2, beta 3. Right? For hypovolemic shock, the drug of choice is going to be what? Noradrenaline, or you can also add on what? Dopamine. And remember, noradrenaline is going to work on not all the receptor. It is going to work on alpha 1, alpha 2, beta 1, right? Not beta 2, right? Then we have got what? Then we have got other kind of shocks. You can also use this particular one, right? Dopamine will be having dose dependent uses. Dopamine dose dependent uses, they have asked you. It can activate your alpha 1, it can activate your beta 1, it can activate your D1 receptor also. It can activate your D1, it can activate your beta 1, it can activate your alpha 1 receptor. D1 is responsible for diuresis, and the dose will be 0 to 2 mcg per kg. This is important. They have asked this question. Beta 1 is responsible for what? Beta 1 is responsible for the same beta 1 functioning, right? The dose will be 2 to 10 mcg per kg. And if you are giving more than 10 mcg per kg, this is going to be what? This is going to be activating alpha 1 receptor, leading to what? Same symptoms, right? Alpha 1, beta 1 will be same symptoms, right? This is what is important, right? So these are the important things we are having. Now, what is going to be the answer in this particular case? Answer is pretty simple. This is going to be what? Acetylcholine, because all these three are going to be the neurotransmitter of sympathetic nervous system. They are going to be neurotransmitters for sympathetic nervous system. This one is the neurotransmitter for parasympathetic nervous system. Okay, Bache? This is going to be the answer in this particular case. Then we have got another question. A 31-year-old female patient is presented to OPD, okay, with the main symptoms or main problem that she is not able to conceive. She is not able to conceive despite trying multiple times. Along with the symptoms of headache, she is having what? Headache. She is having cough for long term, and the X-ray examination shows bronchial wall thickening, right? And she is also having what? Dextrocardia. A lot of answers are given here. Which of the following can be responsible for the condition of this particular patient? Try to answer this one. Is it going to be desmin, lamin, dystrophin, or dynein? Some are answering D, dynein, some are answering C. Okay, let me make you understand this. Which of the following can be responsible for this condition of the patient? What is your diagnosis in this particular case? What is your diagnosis? What are the symptoms we are having? The symptoms are main problem that she is not able to conceive. She is coming to you, she is not able to conceive. I can tell this particular thing that she is having infertility maybe, right? She is having headache, she is having cough, dextrocardia is also noted, bronchial wall thickening is also noted, leading to what? Bronchiectasis, right? So these are the symptoms of what? These are the symptoms of what? Bronchiectasis, cough, headache, dextrocardia. These are the symptoms of a syndrome. What is the name of that syndrome? Very good. This is known as Kartagener syndrome. This is known as Kartagener syndrome. This is a pure physiology question. Kartagener syndrome, which is characterized by BDS. I've told you BDS mnemonic. B for bronchiectasis was there. D for dextrocardia, S for sinusitis, and this patient is having headache. This is due to frontal sinusitis. This headache is due to frontal sinusitis, right? Second thing, she is having cough. Why she is having cough? Because she is having problem with the ciliary movement. Normally the cilia has a function to remove the cough out, right? The normal function of cilia is to remove the cough out. It will be having unidirectional movement, right? So what is going to be the problem here? In Kartagener syndrome, you will be having, the problem is defective ciliary movement. Defective in ciliary movement. This is known as Kartagener syndrome, right? And what is the protein which is going to be involved here? What is the thing which is going to be involved here in defective ciliary movement? Remember, cilia will always have what kind of movement? Unidirectional movement, right? From the sinus, what is going to happen? This air, the air which is going inside, this air will be having some particles, dirt particles, all those things will be going inside, right? So what is going to happen when this thing is going to come out, right? For example, you are driving a bike, you stop, what is going to happen? All these things will come out again, right? With the help of this particular cuff, right? With the help of these sinuses. Sinus का function क्या होता है? What is the function of those paranasal sinuses? How many types of paranasal sinuses do we have? We have got multiple types of paranasal sinuses, which is this one, right? So these paranasal sinuses are going to do what? They are going to do humidification of the air, normalization of the temperature, right? Humidification of the air is going to be important one, right? It is also going to do what? Whatever extra things you are having, they are going to come out through the coughing, right? So when you stop after traveling for such a long period of time, what will happen? You will be having coughing, all those things will be going out, right? This is going to be the basic thing we are having, right? If I told you in body, anytime in your body, in micro also we have discussed, anytime in your body you will be having what? Stasis. Stasis will lead to infection. And you will be having which infection here? Which infection beta here? You will be having sinusitis. What kind of sinusitis? Here the pain, it is suggestive of frontal sinusitis will be there. Frontal sinusitis will be there in this particular case, right? This patient will be having frontal sinusitis. This patient will be having cough. This patient will be having dextrocardia. Why dextrocardia? Because cilia is the one which is responsible for the movement in embryological life. This movement of, normally the heart is formed in the right side. This movement of heart to the left side is because of cilia. Cilia is responsible for that movement, and this patient is having a ciliary defect, that is known as Kartagener syndrome, leading to what? Leading to डेक्स्ट्रोकार्डिया, इसमें हार्ट लेफ्ट में नहीं आएगा, राइट में ही रह जाएगा, राइट. दे विल बी हैविंग थिकनिंग ऑफ द ब्रोंकियल वॉल्स, राइट. कफ विल नॉट बी एबल टू गो आउट, राइट. नथिंग इज गोइंग टू गो आउट. These are going to be the symptoms, right? Why infertility? Simple funda. You will be having every month there will be rupture of the ovaries. You will be having that ovum will be coming out, and that ovum is the secondary oocyte that is coming out, right? Your fimbrias are going to take up this ovum, and now this fimbria is going to transport, this fallopian tube is going to transport what? This ovum to the ampulla. Ampulla is the site for fertilization. But what is going to happen in this particular case? You are not having the movement of ovum from fimbria to ampulla, right? This is going to be leading cause of infertility. Situs inversus is nothing but your dextrocardia. Same story. Situs inversus means dextrocardia, right? So this is going to be your Kartagener syndrome. And remember bache, this Kartagener syndrome is due to desmin or dynin. This is due to dynin. In fact, in the body, this dynin is responsible for what? This dynin is responsible for reverse axonal transport. It is responsible for reverse axonal transport. And two diseases I have told you important. One is going to be rabies. In the last class we have discussed about the rabies, and second one is going to be Clostridium tetani, which is going to cause what? Tetanus. Both of them are going to travel on the backside. So what is going to happen? This thing is going to go through the spinal cord, reverse axonal transport. For example, you have a bite, right? It will be traveling all the way back, right? It will be traveling all the way back to the head. This is going to be rabies. In the cases of tetanus, you are driving a bike, you have road traffic accident, Clostridium tetani spores will come into contact with your blood. Once they will come in contact with your blood will be transporting the things, and this particular thing will be traveling through the spinal cord. It will cause inhibition of glycine and GABA, leading to what? Opisthotonous posture, right? It will go to your muscles. Which muscle in the mouth? Which muscle will be involved? In trismus, which muscle is involved? My question, in trismus, which muscle is involved in the mouth? Okay, try to answer. This rabies is due to which virus, beta? Lissa virus. Type 1 is the most common one, and tetanus is due to Clostridium tetani. Can anyone recall for me what is the culture media for this Clostridium tetani? Is it aerobic bacteria, anaerobic bacteria? Okay, let's try to consolidate the other subjects also. What about this desmin, sir? Let's try to understand what is this desmin, what is this lemmin, what is this dystrophin. These are all of them are known as cytoskeletal filament. They are important one. Right, so we have got two types of cytoskeletal filament. We have got static one, we have got dynamic one. Dynamic means they will be changing the shape and length and size of the filament. Static means it will be stationary. So remember, this is going to be static. Both of them are going to be dynamic. So we have got microfilament, we have got what? Microtubules. Microfilaments and microtubules, they are divided on the basis of diameter. So longest diameter with the tubes, longest one with the tubes, shortest diameter with the filament. छोटा सा diameter किसके साथ होगा बेटा? Filament. Longest diameter is with the tubes, right? So we have got microtubules, we have got intermediate filament, we have got what? Microfilament. तीन चीजें होंगी, microtubules, intermediate filament and microfilaments. So let's try to understand. The first one we have got is about the microfilament. This is going to be your actin. Actin is the contractile protein, right? They will be asking you question in the actin. What is this M protein? What is this M line? Where is the M line? Can anyone recall for me where is the M line? In the sarcomere. What is sarcomere? Sarcomere is this length between these, area between these two Z line is known as what? The area between two Z line is known as what? This is known as sarcomere. This is known as sarcomere. You have got what? Myosin. You have got what? You have got myosin. You have got what? Actin. You have got what? Myosin and actin. This is going to be the funda that we are having, right? This filament that we are having, this bigger one is going to be mota wala filament is going to be what? This filament is going to be myosin. And what is M line? The line which is dividing this particular filament into two halves, this is known as M line. This is known as M line. And non-overlapping part is known as which zone? This zone is known as H zone. This zone is known as H zone. Okay, so these are the things you should remember. what is A band, what is I band? These are the important question you have to remember. What is A band? A band is anisotropic. A band is an isotropic. So you will be having both the things will be there. Both the things will be there in the A band. You will be having myosin, you will be having actin. And what is I band? I band will be isotropic. So you will be having only one thing. What is that only one thing? Either you will be having this particular thing, right? So this is going to be the A, this is going to be the A band. This is going to be the A band, which is going, sorry, this is going to be the I band, which is isotropic. Only and only actin will be there. Here you will be having only actin will be there, no myosin, right? Whereas this band is anisotropic because it is having actin, it is having myosin. Both the things are there. So this is going to be the, this band is known as which band? A band, anisotropic band. Okay, ये चीजें पता होनी चाहिए. These are the important thing. Very good, Shraddha. You have got what? We have got medial pterygoid muscle. Medial pterygoid muscle is the muscle for what? It is the muscle which is having the trismus. Second thing, Robertson cooked meat media will be having, will be the culture media for this particular thing. RCM, it is anaerobic bacteria. Remember, anaerobic. पैर के अंदर चला गया तो गैस गैंग्रीन करा देगा. That is the another species, Paraphragmogenesis, also known as Welshi, Clostridium welshi. And remember that Clostridium welshi was also responsible for the putrefaction. आप FMT में पढ़ते हो putrefaction, that is also due to this welshi, which is having lecithinase activity. Okay, beta. Now next thing we have got is keratin. These are the static filaments that we are having. इनका साइज बड़ा छोटा नहीं होता. Let's try to understand. Like we discuss about cytokeratin 14, cytokeratin 20, right? These are the keratin. They are the marker for what? They are the static filament. They are the marker for carcinoma. Any tumor arising from epithelial origin, this is considered as carcinoma. Desmin is a marker for sarcoma, beta. Desmin is a marker for sarcoma. Desmin is a marker for sarcoma, right? Rhabdomyosarcoma, osteosarcoma. Sarcoma is a tumor which is arising from muscles or bones, right? Sarcoma is going to arise from muscles or bones. Vimentin की वजह से क्या होगा? Fibrosarcoma. Vimentin is a marker for fibrosarcoma. GFAP, glial fibrillary acidic protein, is a marker for, it is a marker for astrocytoma. And lemon mutation will lead to what? Progeria. Progeria is a disease. Pro means faster, geria means geriatric, right? Faster aging will be there, which you have seen in the cases of what? In the cases of PA movie, right? PA movie you have seen, you will be having what? Faster aging, that is known as progeria. That is known as progeria. Progeria was there. Then we have got some microtubules. What are these microtubules? First one we have got is kinesin. Kinesin का function क्या होता है? What is the function of kinesin? It is responsible for forward axonal transport. It is responsible for forward axonal transport. If suppose this is a neuron, this is the dendrite, this is the axon. This part is known as axon. This part is known as cell body. This part is known as synapse, and here you will be having what? Multiple dendrites will be there, right? So this is going to be the normal funda. If some information is going in this direction, from forward direction, this is known as forward axonal transport, FAT. Okay, what is RAT? Reverse axonal transport. That means the information from this particular direction is coming now from the synapse to cell body. Forward axonal transport is cell body to synapse, right? Reverse axonal transport is what? Reverse axonal transport is what? It is going to be synapse to cell body. It is going to be synapse to cell body, and we have already seen three things. This is going to be your dynein. We have already seen three things. What are those three things we have seen? We have seen about the dynein mutation will lead to which syndrome? Kartagener syndrome. Kartagener syndrome characterized by BDS, bronchiectasis, dextrocardia, sinusitis, right? This is the correct Kartagener syndrome. Second thing we have discussed about this dynein. दूसरी चीज कहाँ पड़ी dynein के बारे में? This dynein we have discussed where? We have discussed about this in the two important diseases, pathology of two important diseases. That is going to be reverse axonal transport. One is going to be tetanus, another one is going to be rabies. Both of them are vaccine preventable diseases, है ना? दोनों vaccine preventable है. right? Then we have got what? Tubulin. Tubulin is responsible for cell division, beta. Tubulin is responsible for cell division, right? We can inhibit these tubulin, with the help of certain drugs. What are the drugs we are having? We are having drugs like colchicine. We have got drugs like vincristine, vinblastine. These are your vincristine. We have drugs like griseofulvin. They are going to be working on this particular thing. This colchicine, can anyone tell me where else do we use this colchicine? It is the drug of choice in the cases of, it is the drug we are going to use in the cases of, it is the drug of choice in the cases of colchicine. कहाँ सुना है? It can cause a side effect of myopathy. Try to answer if you can recall. This vincristine we are using as an anti-cancer drug because it is going to inhibit the cell division. It is going to inhibit the cell division, anti-cancer. What about this colchicine? This colchicine we are using, very good Krishna, this is what we are using in the cases of acute gout. In the cases of acute gout में drug of choice क्या है बेटा? Acute gout में drug of choice was एंडोमेथासिन. कौन सा नहीं देना? एस्पिरिन नहीं देना. यू नेवर गिव एस्पिरिन. एस्पिरिन इज गोइंग टू इंक्रीज द यूरिक एसिड, एंड यूरिक एसिड इज द एंड प्रोडक्ट ऑफ न्यूक्लिक एसिड लाइक xanthine, है ना, उसका एंड प्रोडक्ट है, राइट? सो दिस इज गोइंग टू बी द ड्रग ऑफ चॉइस, दैट इज गोइंग टू बी द एंडोमेथासिन. क्या नहीं देना? एस्पिरिन नहीं देना, राइट? एंड मोस्ट इफेक्टिव ड्रग इफ दे आस्क यू, देन योर आंसर विल बी व्हाट? मोस्ट इफेक्टिव if they ask you, then your answer will be what? Colchicine. Most effective is colchicine. This is going to be gout. Okay, pain will be there in the first toe joint, that MTP joint that we are having, first joint that we are having. This is going to be MTP. Pain will be there, right? You will be having increased swelling will be there. All these things will be there. You will be having pain. You will be having you will be having swelling, tenderness will be there. You can do what? Check the levels of uric acid. You can also do what? X-rays. You can identify this particular thing. The first line for acute gout, you will be giving endomethacin, and you can also give the most effective drug, that is colchicine. But what is the side effect? Yes, side effect is important. It can cause what? Myopathy, beta. It can cause what? Myopathy. That is why we are avoiding in the first place myopathy. And the most common drugs which we are using are going to cause myopathy. These are going to be your steroids. They can also cause what? Myopathy, right? This is going to be the thing we are having. Then we have got what? Then we have got vincristine, which is an anti-cancer drug. And remember, this griseofulvin is the drug of choice in which tinea? It is the drug of choice in tinea capitis also. This griseofulvin has got a lot of affinity for what? Affinity for keratin, right? So we are using this particular drug in the cases of tinea capitis like carrion and favus. इनमें ये drug of choice है, carrion and favus. In cases of carrion or in the cases of favus, this is going to be the drug of choice. In the last class we have discussed what you will find in the carrion. Just try to answer if you can recall what you will find in the carrion, right? Carrion में क्या appearance will be there? Okay, so this is about this particular thing. Now let's try to answer this one. Desmin mutation. Desmin is a marker. It is intermediate filament. This is a marker for sarcoma, so it cannot be the answer here. This is a marker for sarcoma. Lemon mutation will lead to what? Lemon mutation will lead to progeria, beta. It is going to cause what? Progeria. And dystrophin. Dystrophin is something you will be finding in the gene number 1, right? Chromosome number 1. It is the biggest gene that we are having. And mutation of dystrophin will lead to what? Mutation of dystrophin will lead to what, bacha? It can cause Duchenne muscular dystrophy if there is complete mutation. If there is partial mutation, we can have what? Baker's muscular dystrophy for partial mutation. Which is going to be more dangerous? Duchenne muscular dystrophy. Which is going to have, this is going to have a sign that you will be finding Gower sign positive will be there. Gower sign will be positive. What is this Gower sign? This baby cannot stand up directly, right? This baby will be using the body support. ये body support लगा के खड़ा होगा, है ना बच्चा? So this is going to be what? This is going to be dystrophin that we have got. Duchenne muscular dystrophy. If there is complete loss, बंदा जल्दी मर जाएगा. And remember, for muscular dystrophy, always remember you will be finding what? You will be finding characteristic sign. This is going to be pseudo hypertrophy of calf muscle. Pseudo hypertrophy of calf muscle will be there. right? This is going to be another thing that will be present in the muscular dystrophies, right? It is suggestive of muscular dystrophy. So with this thing, we are done with this question also, right? The next thing we are having, which of the following junction is helping the cell to bind with the basement membrane? So which of the thing is going to help the cell to bind with the basement membrane? Try to answer. बेटा वो दवाइयाँ हम लोग chronic gout में यूज में लेते हैं. Those other drugs we will be using in the chronic gout. In chronic gout we are going to use those drugs like febuxostat, allopurinol. These are the drugs we are using in the chronic gout. Rasburicase, pegloticase, वो सब किसकी दवाइयाँ हैं? वो सब दवाइयाँ chronic gout के, right? Try to answer this one. Which of the following junction is helping the cell to bind with the basement membrane? Which of the following junction helping the cells to bind with the basement membrane? So these are the two cells. First of all, let me make you understand what are the layers do we have. You're answering B. Hemidesmosomes. Okay, so we have got what? We have got skin. Skin will be having three layers. Skin is also known as dermis, right? We have got skin. Skin is also known as dermis. Above dermis will be epidermis. Below dermis will be hypodermis, bacha. Hypodermis, right? Above dermis will be epidermis. Below dermis will be hypodermis. This epidermis will be in turn having 5 layers. Okay, this is going to be cute ladies get smart boys. These are going to be 5 layers. This is going to be stratum corneum, stratum lucidium, stratum granulosum, stratum spinosum, stratum basal, right? This is the high time, guys. Okay, answer me. These are the 5 layers we are having. Then we have got dermoepidermal junction, and then we have got what? Then we have got the dermis. Then we have got the dermis. Two types of dermis. This is going to be reticular dermis. This is going to be papillary dermis. And then we have got what? Hypodermis, also known as subcutaneous, right? This is how this arrangement is going to be there, right? So how these layers are binded together with each other, how these cells are binded together in the layers with each other, this is going to be the question that we are discussing. So how these two keratinocytes are binded together, just try to understand how these two keratinocytes are binded together. This is one keratinocyte. This keratinocyte is a cell which is present in the skin. This is a keratinocyte. 95% of the cells in the skin are going to be keratinocytes. Remember, these two keratinocytes are binded together with the help of what? With the help of desmosomes. Two keratinocytes are binded together with the help of desmosome. One keratinocyte, another keratinocyte with the help of desmosomes, right? This is the desmosomes. Now, these keratinocytes are binded together with the dermoepidermal junction or basement membrane zone with the help of what? This is their question. So they are asking this dermoepidermal junction. They are asking the question how these things are binded together. Okay, how these things are binded together. ये सारे जो भी यहाँ पर cells है, whatever cells we are having keratinocytes, they are binded together with the help of desmosomes. But how they are binded with the ground? How they are binded with the ground? This is what is their question, right? How they are binded with the basement membrane zone. So remember, these proteins are known as hemidesmosomes. These proteins are known as hemidesmosomes. These are going to be your hemidesmosomes. These are going to be hemidesmosomes. They are present in the basement membrane zone. Basement membrane zone, also known as dermoepidermal junction. Between dermis and epidermis, between dermis Between dermis and epidermis there is a junction. This is known as dermoepidermal junction, also known as basement membrane zone, right? What other mechanisms we are having apart from this desmosomes? What other connections we are having between the cells? Like we have got gap junctions, we have got tight junction. Two cells are very tightly connected. This is the tight junction. Two cells are connected, but they are having some gap in between. This is going to be your gap junction. This is going to be your gap junction. So let's try to recap all these type of cells and all this type of junctions that we are having, right? So beginning with the first one that we have got, this is going to be your tight junction. This tight junction is going to be present. It is made up of some important proteins. What are these some important proteins? These are going to be your claudin and occludin. These are going to be your claudin and occludin. And this tight junction you will be finding in the brain. In the brain you will be having what? Like you are having blood brain barrier. You have got blood brain barrier in the brain, right? This is going to be the first thing. Second, you are also having blood testis barrier. Okay, blood testis barrier. And remember, this blood testis barrier is because of which cells? This is because of Sertoli cells, right? This is another question they have asked you from Obsgyne. This blood testis barrier is because of Sertoli cells. What kind of cells which are having over there? These are going to be what kind of junctions? If they ask you, these are going to be tight junctions, and these tight junctions are made up of what? Claudin and occludin. Which proteins? Claudin and occludin are responsible for the formation of these tight junctions, right? They are very tightly, compactly packed. That is why all the things are not going into your brain, right? They are compactly packed, right? This is going to be the tight junction that we are having. Second junction we are having is the adherent junction, which is responsible for the connections, right? Adherent junction. We have proteins like E-cadherin. You understand about the cadherins, right? We have got cadherins. These are going to be the cadherin proteins we are having. This is also responsible for the actin formation. It is also responsible for the formation of actin. Then we have got desmosomes. Desmosomes, you already know the function is to make two keratinocytes together. What are the desmosomal proteins we are having? What are the examples of desmosomal proteins? We have got desmoglin, we have got desmocolin, we have got desmoplakin, we have got plakoglobin. These are your desmosomal proteins that we are having. Maximum desmosomes you are finding in stratum spinosum, है ना? Stratum spinosum. Then we have got gap junctions, beta. Then we have got gap junctions. These gap junctions are maximum in your heart, maximum in your heart, and they are made up of which protein? They are made up of connections. They are made up of connection protein. कौन से protein से बना होगा? Connections, right? And what is the function of this connection protein? They are going to make the connections between these gap junctions, so you can understand these connections, right? And that is what is responsible for the functional syncytium, right? All the heart muscles are contracting at the same time. Why? Because they are having the gap junctions. So impulses, so the ions can move from one cell to another cell very fast, right? Which is why these connections are going to be very, very important that we are having. These are known as connections that we are having, right? Apart from that, if you are having mutation of these connections, you will be having a disease that is known as, what is the name of the disease, beta? Connection mutation will lead to Charcot-Marie tooth disease. This is going to cause what? Charcot-Marie tooth disease that we are having. This is due to mutation in connections. Charcot-Marie tooth disease will be there. Then we have got this hemidesmosomal proteins. These hemidesmosomes that we are having, they are your BPAG1, they are your BPAG2, integrin, plectin, right? These are the hemidesmosomal proteins, right? If you are having what? BPAG mutation. BPAG mutation is going to cause what? Bullous pemphigoid. It is going to cause what, Bacha? Bullous pemphigoid. It is going to cause what? Bullous pemphigoid. Okay, this is going to cause what? Bullous pemphigoid. And this bullous pemphigoid, bulla means what? Bulla means clear fluid filled lesion. More than 1 centimeter is known as what? This is known as bulla. So you can appreciate this is a clear fluid filled lesion more than 1 centimeter. This is known as bulla. This is your bullous pemphigoid. Then we have got this. This is going to be your desmosomal disorder. This disease is known as what? Pemphigus. Remember beta, pemphigus, S for S याद रखना है. This is going to be superficial, whereas this bulla or bullous pemphigoid, bullous pemphigoid will be the disease. D for D, it is going to be a deep disorder. It is going to be a deep disorder. Okay, it is going to be a deep disorder. So here bullous pemphigoid is going to take place in this particular part. Remember, BP is the disease which is going to happen here, whereas this another bullous another disease that we are having, that is going to be pemphigus. You will be finding pemphigus somewhat here and somewhat here, right? So this is going to be the difference we are having. This is going to be the differences that we are having. Okay, I hope you got this. So what is going to be your answer now? Everyone, just try to answer this one. Just try to answer this one. Yeah. This is going to be what? Desmosome, semidesmosomes, tight junction or gap junction? B. Yes, this is going to be B, right? So they are asking about the cell binding to the basement membrane. They are asking the cell binding to the basement membrane. Who is going to help you? This is not going to be the other junctions. This is definitely going to be the B. This is going to be the hemidesmosomes that we are having, right? The next question given below is the pressure volume graph of cardiac cycle. Okay, this is a pressure volume graph of cardiac cycle. Identify the point in the given diagram. You need to identify the point in the given diagram, right? You need to identify which point. I am asking about this A point. You need to identify this A point in the given diagram. So what is this A point is going to tell us about? This graph is known as what? This graph is known as pressure volume graph. This graph is known as what? Pressure volume graph, right? And this graph is going to tell us about what? Batao. Am I audible now? Am I audible, guys? Please let me know, am I audible now? All right. Okay. So now we are going to discuss. So the next question we are having given below is the pressure volume graph of cardiac cycle. Identify the point A in the given diagram. You need to identify what is this point A which is given in this particular diagram. This is a pressure volume graph. This is a pressure volume graph where you will be having this x-axis which is going to tell us about the volume. This is going to be your y-axis which is going to tell us about the pressure, right? So now just try to answer. All right. So let's try to understand this pressure volume graph. What is this pressure volume graph? Yes. So what is this pressure volume graph? If you understand this pressure volume graph, you will easily understand what are the murmurs that we can have, what is early systolic, what is late systolic, what is mid systolic. All these things can be explained with the help of this particular simple graph, right? So what is this graph we are having? Just remember this thing. We are going to have 4 chambers. Let me make a rough diagram so that you can revise it better. So we are going to have this 4 chambers in the heart. This is your right atrium, right ventricle, left atrium and left ventricle. The blood from the left ventricle is going to go to the body. This is going to go to the aorta, right? And the blood from the right ventricle will go into the lungs. This is going to be the pulmonary wall that you are going to have over here. You are going to have aortic valve over here, right? This is going to be aortic valve. This is going to be pulmonary valve. Then you have also got 2 other valves. This is going to be 3 number will be first. This is going to be tricuspid valve. This is going to be your bicuspid valve. Bicuspid is also known as mitral valve. This bicuspid is also known as mitral valve. I'll just revise it very quickly. Okay, just be with me. We already know the wall of left ventricle is going to be bigger, and also the wall of right ventricle is going to be bigger because it needs to transport blood throughout the body, right? So it is going to get bigger, right? So let's try to understand how it is going to happen. Okay, the blood from the left ventricle is going to the body. It will be go to aorta, aorta to body, and then this particular blood, same blood will come back to the right atrium, then right ventricle, then it will go to the lungs for oxygenation. After oxygenation, this blood will enter into left atrium, then left ventricle, then aorta, and then body. This is known as double circulation. This is known as double circulation that we are having, right? So now I'm just taking a single point here. This single point that I'm taking is the point B. Okay, bacha? The single point that I'm taking is the point B, and just follow the cycle. Okay, the few things you need to remember. What is the few things? Systole means what? Which is systole means contraction, and systole is going to happen in the depolarization. Depolarization, systole, contraction, सब एक ही बात है, right? What is diastole? Diastole is going to be relaxation, and this is going to be repolarization. दो बातें clear है? This is going to be repolarization. What else you need to remember? If I'm talking about this side of the heart, this side will automatically follow, right? I'm going to teach you this side of the heart. I will say left atrium is contracting. That means right atrium is also contracting. If I say mitral valve is contracting, remember tricuspid is also contracting. And you will only hear the sound if there is closure of the valve. Closure will produce some kind of sound, right? Sound will only come to, you get to hear the sound when there is closure of the valves, right? So what is going to be the thing we are having? Let's begin with from any point. Let's begin with the point B, right? So point B, assume like that you are having what? 120 ml of blood over here. You are having 120 ml of blood over here. Just assume at point B you are having 120 ml of blood. Now what is going to happen? Follow the cycle. Just be with me for the 2-3 minutes and you will be able to understand, right? So what is going to happen at point B? You are having 120 ml blood here. Can I directly supply this blood to the body? No, it cannot. It requires pressure because it needs to transport the blood. Left ventricle needs to transport the blood throughout your body. And throughout our body means it requires what? It requires power, right? So from where you will get this power? Just try to understand this. You will be having first change is going to be isovolumic contraction. That means same volume you are going to contract your heart. Same volume means what is the volume we are having? 120 ml. You will be having isovolumic contraction at 120 ml. You will be having increase in the pressure. Increase in the pressure till what point? Till the point C. Till the point C, you will be having increase in the pressure. In the pressure will be increased here. Volume remains same, 120 ml. Your wall of the ventricles will start to contract. You will be having increase in the pressure. At point C, when the pressure will reach up till a certain value, what is going to happen? You will be having opening of which valve बचे? कौन सा valve खुलेगा? Aortic valve will open at point C, and what will happen to the blood? Now you will be having rapid ejection, you will be having slow ejection. This blood will be going to the aorta, it will be going to the body. This is going to be rapid ejection, this is going to be slow ejection. After beta rapid ejection and slow ejection, what needs to done? We needs to close this valve. We needs to close this valve. This is going to close at point D. This is going to close at point D. तो फिर से समझो क्या होगा point B पे. You will be having opening. You will be having closure of mitral valve will be there. Basically, just begin with the point B. You will be having some amount of blood will be there here. Right, you cannot throw all the blood directly, so you need to increase the pressure. This is known as isovolumic contraction. Same volume contraction will be there. At point C, you will be having opening of the aortic valve. Opening will produce any sound? No, it will not produce any sound. Only closure will produce some sound. Closure will produce sound. So there will be no sound production here. And then what is going to happen? Then you will be having what? Then you will be having rapid ejection. You will be having slow ejection. This blood will be going to the body. After the blood will be going to the body, complete blood is not going to go to the body. Some amount of blood will be left here. Out of that 120, 50 ml will stay here. 50 ml will stay here, right? Only 70 ml will be going out in the body, right? Only 70 out of that 120, only 70 will go out. 50 ml will stay here. And now what will happen at point D? You will be having closure of the aortic valve. Now you tell me, closure will produce some sound. Yes, closure will produce some sound, and this is going to be the sound that you will be having. This is known as S2 sound. Which sound will be there? S2 sound. So S2 sound is due to closure of which valve? Mitral valve, aortic valve, tricuspid valve. What is going to be your answer? It is due to closure of aortic valve, S2. Then what is going to happen? You will be having 50 ml here. This valve is closed. This valve is closed. And can I open this valve now? Can I open the mitral valve now? No, I cannot open. Why? Because we are having lots of pressure here. Can you appreciate the pressure is more? If I start to open this valve, or there is some pathologies like regurgitation or like stenosis is there, or some prolapse is there. If there is any pathology, what is going to happen? You will be having backflow of blood, because you will be having what? You will be having increase in the pressure over here. Pressure यहाँ पर ज़्यादा होगा तो क्या backflow हो सकता है? और इसी को क्या बोलते हो? इसी को बोलते हो regurgitation. You can have mitral valve stenosis, you can have regurgitation, you can have prolapse, right? This is going to be the phase. Normally what should be happening? According to physiology, it should be closed. It should be closed. This is the normal functioning. Pathology में क्या होगा? You will be having backflow of the blood. This is going to be regurgitation. Now what is going to happen? They should be closed. तो पहली चीज क्या होनी चाहिए? First thing, isovolumic relaxation. You need to decrease the pressure. ढक्कन को, ये ढक्कन खोलने से पहले हमने क्या करना है? हमने इसका प्रेशर कम करना है. So this is going to decrease the pressure. This pressure will be decreased till zero. This pressure will decrease till zero. And when the pressure is zero, what is going to happen? Now you can open this. Now you can open mitral valve. So at point A, what is going to happen? Now at point A, mitral valve will open. Mitral means tricuspid will also open, and now you will be having supply of blood from above chambers to the below chambers. और अब क्या होगा? अब यहाँ पर filling होगा. कितना filling होगा? 50 ml was there. More 70 will come. It will become what? 120. It will become 120 again, and now you will be having 120 ml. और जब 120 ml हो जाएगा, right? It is going to get closed. This valve will be closing, right? This is your mitral valve, and this is going to give you one sound, and this sound is going to be which sound? This sound is going to be S1 sound. बेटा S1 sound यहाँ पर आ जाएगा. S1 is due to closure of mitral valve. So S1 sound is going to be there due to closure of mitral valve. Then what is going to happen? Then you will be having increase in the pressure. Isovolumic contraction will be there. Opening of the valve will be there. You will be having the same cycle going on again and again. Can I divide this cycle into two halves? Yes, I can divide this cycle into two halves, because I know contraction or systole or depolarization are the same thing. This is contraction, this is systole, this is depolarization. So you can remember, this is all part of systole. These are the contraction, isovolumic contraction, rapid ejection, slow ejection. All these things are what? These are the contractions. What is relaxation? Diastole, isovolumic relaxation. What is going to happen here? There will be slow filling, rapid filling will be there, right? This filling is going to be also coming under the diastole phase. So whatever amount of blood you are having at the end of the systole, this is known as end systolic volume. तो बॉडी में 120 में से कितना फेंक दिया, 70 डाल दिया बॉडी के अंदर, कितना बचा 50 ml. So what is the end systole? At the end of systole, whatever volume is there, this is known as end systolic volume. This is going to be 50 ml. So what is going to be end systolic volume? This is going to be 50 ml. What is end diastolic volume? This is your diastole. At the end of diastole, what is the volume? 120 ml, right? So what is end diastolic volume? This is going to be 120 ml. 120 ml, right? They will ask you how to calculate a stroke volume. You can calculate a stroke volume. End diastolic minus end systolic, stroke volume will be 70. 70 multiplied by the heart rate, you will get what? Cardiac output. What is cardiac output? The stroke volume into heart rate. You will get cardiac output. Suppose heart rate is 70, stroke volume is 70, cardiac output will be somewhat around 5 liter. This is going to be the cardiac output, right? This is a single cycle. If you understand, you will understand all other things around it, right? Now what you need to understand, अगर सिस्टोल में कोई भी एक्स्ट्रा साउंड आ रहा है, if you are finding any other extra sound, this is known as what बच्चे? This is known as murmur, right? If you are finding murmur, this is going to be S1, this is going to be lub, this is going to be dub, this is going to be dub, right? So you have got lub sound, you have got dub sound, and if you are finding any sound somewhere between lub and dub, okay, first earth sound, lub, dub, lub, dub. If you are finding something in the first earth sound, this is going to be what? Systolic murmur. This is going to be considered as systolic murmur. If you are hearing something between dub and lub, this is considered as the diastolic murmur. Diastolic murmur. We can have early systolic murmur, mid systolic murmur, late systolic murmur. Early diastolic, mid diastolic, late diastolic murmur. This is how you are going to understand this, right? This cycle is very, very important. Let you understand a lot of things, right? You got this? Right? So what is this point B they are asking about? This is the point A. In the question they are asking about point A. So what is point A? A point पे क्या होगा? You will be having opening of mitral valve closure will be at the point B, leading to which heart sound? S1 heart sound. Then you will be having isovolumic contraction. Then you will be having opening of the aortic valve will be there. Aortic valve closure will give you S2 sound. And after S2, you require to decrease the pressure. Isovolumic relaxation will be there. And then this is going to be the cardiac cycle that we are having. This is the cardiac cycle that we are having. Okay, bache? So what is going to be your answer in this particular case? Now just try to identify and answer me. I hope you got this cardiac cycle. Very, very simple, very, very easy and understandable, right? I just try to make it very, very simple for you. So your answer in this case is going to be isovolumic contraction. कहाँ होगा? Where is going to be isovolumic contraction? Isovolumic contraction is going to be happening over here. This is isovolumic contraction. This is going to be opening of mitral valve. This is going to be closure of mitral valve. This is going to be isovolumic relaxation, opening of which valve? Mitral valve, right? So this is going to be the question and this is going to be the answer. ऐसा question हमने गलत नहीं करना. Two things we have done. We have got the understanding. We have also got the question, right? This is going to be the question. यहाँ से कुछ भी पूछ सकते हैं. They can ask you anything. All things are correlated here, right? Simple है. चलो next. All of the following substances increases the release of gastric acid secretions except. All of the following substances increases the release of gastric acid secretions except. So what is going to be there? All are going to be stimulatory except. So let's try to understand this particular cell. What is this particular cell? This is known as parietal cell. So whenever you are eating food, we have got three phases of digestion. Okay, what is the function of GIT? The function of GIT is to digest the food and to absorb the food. Digestion and absorption. This is the function of GIT. Digestion means whatever complex carbohydrate you are eating, it is going to become glucose, and absorption means glucose, it will be made in the mucosa. In submucosa, you are going to have blood vessel and this glucose will be traveling into submucosa. This is known as absorption, right? These are the two things we are going to have, digestion and absorption, right? Next thing we are having, what is the function? Whenever you are having the food in the GIT, what is going to happen? Your GIT will produce what? Acid. your GIT will produce acid, and we have got three phases of digestion. First is cephalic phase. Second phase is going to be the gastric one, where the food is in the gastrium, and third phase is going to be your intestinal phase. Cephalic phase, that means food is where? Food is not in the body, it's in the head, right? Food is in the head. You are watching reel in the night time, you will be having cephalic phase, right? Cephalic phase can itself lead to 30% of the acid release. Beta, kitna acid release ho jayega? 30% of the acid release will be there. This is going to be your cephalic phase of digestion. Cephalic phase of digestion will be there. You will be having what? 30% of the acid release will be there. Second one we have got is gastric phase. Now the food is in the gastrium. Food is in the gastrium. And intestinal phase, that means now the food is in the intestine, still you are having acid release. This is going to be gastric phase. Remember, this cephalic phase is coming under feed forward mechanism. What kind of mechanism is it? Feed forward mechanism. We have got positive feedback, negative feedback, and feed forward mechanism. Feed forward mechanism, this is going to be your cephalic phase of digestion, right? It is also known as psychic stimuli. If you think about food and you have what? You have acid release in the stomach. This is also known as psychic stimuli. Psychic stimuli, right? Now, what are the features you will be having? You will be having release of acid from which cells? These are going to be your parietal cells, and parietal cells are going to make acid with the help of this this particular carbonic anhydrase enzyme that we are having. It is under control of three things. One is acetylcholine, second one is histamine, third one is gastrin. This acetylcholine will act via your M1 receptor. It is going to activate your it is going to make the acid secretion. Second is going to be your H2 receptor, leading to what? Histamine. This is also going to cause what? Increase in the acid release, right? And third thing is going to be gastrin, coming from the G cells. It is going to come from the G cells, and this is also responsible for the acid release, right? So what they are going to do, they are going to make this H2 and CO2, they are going to make H2CO3, and now this bicarb will be formed, and this H plus will be formed, and this H plus will be coming into the lumen. This is the lumen, this is the mucosa, this is the submucosa. Here you will be having submucosa, will be having the glands, right? So this is the submucosa we are having, right? So what is going to happen? This H plus will be coming into the lumen. When this H plus is going to come into the lumen, what is going to happen? Second thing, you will be having bicarb chloride exchanger. This is going to be your bicarb chloride exchanger, right? This is the also known as this exchanger is also known as Hamburger shift. This particular thing is responsible for the transport of what? CO2. CO2 transport is going to take place with the help of this bicarbonate. Oxygen transport with the help of hemoglobin. So this is going to be CO2 bicarb exchanger that we are having. This is also considered as Hamburger shift. Hamburger shift, right? So what is going to happen? This chloride is going to come here. H plus is already there, chloride is there. They are going to meet up. They are going to make what? They are going to make H plus, Cl minus is going to make what? HCl, hydrochloric acid. This is the acid we are having, right? Abhi kya karna hai? This acid is going to increase by three things: acetylcholine, histamine, and gastrin. They are the substances which are going to make increase in the acid release. But one of the substance is going to be there which is going to stop the acid release, or you can also call it as a universal inhibitor. That is known as, उसका क्या नाम है? This is known as somatostatin, coming from the delta cells, right? This somatostatin is responsible for the blockage, for the decrease in the acid release. It is going to decrease the acid release. What else can decrease the acid release, beta? और क्या acid release को कम कर सकता है? This is going to be what? This is going to be the negative feedback by acid itself. So negative feedback by acid itself is going to decrease the release. Second thing is going to be this somatostatin, which is also responsible for the decrease in the acid release. This somatostatin that we are having, bache, this somatostatin is inhibited by a bacteria. What is that bacteria? What is that bacteria which is going to cause ulcers or which can also cause cancers? Let me give you the pathology, how it is going to work, right? Let me give you the understanding. So we have got a bacteria that is known as H. pylori, which is responsible for the gastric ulcer. This H. pylori is going to do what? This H. pylori is going to do what? inhibition of somatostatin. ये किसको बंद कर देगा? It is going to damage the delta cells. It is going to damage the delta cells. And if delta cells are damaged, there will be no somatostatin, right? And what is the function of somatostatin? Somatostatin has a function to stop the release of gastrin. It will stop the gastrin, right? It has a function to stop the gastrin G cell. It is going to inhibit the G cells, and G cells are the cells which are going to release what? Gastrin. And we already get to know that gastrin is responsible for the acid production. Yes or no? Three things responsible for acid production. First is going to be acetylcholine, second is histamine, third is going to be gastrin, right? So what is going to happen? Acetylcholine, remember parasympathetic nervous system. In GIT you are having M1 receptor, and this is the same M1 receptor that we are talking about. So if you have this H. pylori infection, this H. pylori is going to kill this delta cells. There will be decrease in the levels of somatostatin. Decreased somatostatin means there will be no break on the G cells. No break on the G cells will lead to what? Overactivation of these G cells. Increase in gastrin will lead to increase in acid, and increase in acid will lead to what? Ulcer formation. This is how we are going to get the ulcer, right? Because of this H. pylori, it is going to change the pH also, but second thing it is going to do is going to the inhibition of this delta cells. This delta cell inhibition will lead to inhibition of the break, and if there is a break fail, you will be having excess of acid, and this is going to cause what? More ulcer production, right? So this is the basic funda we are having. Now what we need to do, we need to block all these things. We need to give the drugs to these patients. I'm just giving you verbally the first thing you can give. You can block this acetylcholine. This is the exam question that we are having. All of the following factors are increasing acid release except. Answer will be what now? Answer will be somatostatin. Histamine will increase the acid release. Gastrin will increase the acid release. And this acetylcholine will increase the acid release. In fact, we have got one cancer. This is known as G cell gastrinoma beta. G cell gastrinoma, also known as which syndrome? Zollinger-Ellison syndrome. This is also known as Zollinger-Ellison syndrome, which is a G cell gastrinoma, right? Here also you will be having lots and lots of acidity will be there. More acid will lead to definitely ulcer formation, right? So we can give what drugs we can give. We can give histamine blocker. These are your H2 blockers are going to be your Rentec group of drugs, ranitidine, cimetidine, nizatidine, famotidine, right? M1 blocker are going to be your tilenzepine and pirenzepine. And then we have got proton pump inhibitor. These are going to be your pantoprazole, omeprazole, lansoprazole, right? These are going to be your pantoprazole, omeprazole, lansoprazole group of drugs. These are going to block this proton pump, right? Their half life is not that much. ये दवाइयाँ 2-3 घंटे काम करती है, but they are going to kill this particular pump. और इस पंप को दोबारा से बनने के लिए टाइम लग जाता है 24 to 48 hours. They should be given empty stomach. This is going to be the thing. For H. pylori, you can give cap therapy. This is going to be clarithromycin. Micro में मैंने पढ़ाया था. Clarithromycin, amoxicillin, and P for PPI. Right? This is going to be the cap therapy, and you can also. This is known as triple therapy. We can also give quadruple therapy. In quadruple therapy, you are going to add on what? You can add on bismuth substrate. You can also add on sucralfate like drugs. These are going to be your quadruple therapy. Right? Triple therapy, quadruple therapy is going to kill this particular thing. Right? We have got different type of ulcers also, but ulcers, I think I'll just give you brief insight. Right? Which is the patient who is going to have? We can have gastric ulcer. We can have duodenal ulcer. We can have gastric ulcer. We can have duodenal ulcer. What is the patient who is going to have gastric ulcer? Remember, this gastric ulcer patient will be coming to you, and he will be having pain, right? And this pain will be relieved by further eating. This pain will be relieved by vomiting. If you are having ulcer in the gastrium, this pain will be relieved by vomiting. And if you have ulcer in the duodenum, this pain will be relieved by further eating beta. So when you are going to eat again, this pain will be relieved. This pain will be decreased on further eating. If you are having pain, this pain will be decreased on further eating. तो अगर ये पेशेंट बार बार वॉमिटिंग करेगा, दिस इज गोइंग टू बी अ थिन पेशेंट, दिस इज गोइंग टू बी अ थिक patient, because this patient is eating again and again, this patient is vomiting again and again, right? So in this question, your answer will be what? A. Answer will be A here. The next question we have got, which of the following hormone is coming from the layer shown in the diagram below, and what is the function of this particular hormone? So what is the hormone that is coming from this particular layer A? From this particular part, which hormone will be coming? Try to answer this one. Tell me. Which is the hormone that is going to come from the layer shown below in the diagram? कौन सा हार्मोन निकलेगा इस पर्टिकुलर लेयर में से? द फर्स्ट वन दैट वी आर हैविंग. This is the cross section of which gland? Try to look for the options. If you don't understand from here, try to look for the options. What are the options we are having? Adrenaline, we have got ADH, we have got aldosterone, we have got cortisol. From which gland these hormones are going to come? कौन सी ग्लैंड में से ये हार्मोन निकलेंगे? Adrenal gland. Very good. This is going to be which gland, beta? This is going to be your adrenal gland. Adrenal gland, right? Adrenal gland has got how many parts? This is your previous year exam question. So we have got the gland, and what is the name of this gland? This gland is known as suprarenal gland. This is going to be the suprarenal gland that we are having. This is known as adrenal gland. This is known as adrenal gland, right? Adrenal gland. So let's try to understand what are the parts of this adrenal gland. It will be having two important major parts. One is going to be cortex, one is going to be medulla. One is going to be cortex, another one is going to be medulla. And this cortex will be having in turn three layers. These are going to be G, F and R. G, F and R. These are going to be the three layers. So let's try to understand what are these layers that we are having, right? So this is going to be your zona glomerulosa. Zona glomerulosa. This is going to be your zona fasciculata. This is going to be your zona reticularis. Zona fasciculata, zona reticularis. And lastly we have got is, this is going to be what? This is going to be zona. This is not zona, this is the medulla. This is the adrenal medulla that we are having, right? These are three parts. These three parts are the parts of cortex. This is known as adrenal cortex. This is adrenal cortex, and the lower one is going to be adrenal medulla. This is the medullary part. This is the medullary part. So from cortex you need to remember three things. First is going to be salt. This is going to be the mineralocorticoid. This is going to be the mineralocorticoid that we are having, which is also known as aldosterone, which is also known as aldosterone. They have given you this particular question. They have marked this layer. They have asked you what is the hormone which is going to come. Now they can ask you where this hormone is going to go and work. This aldosterone will go to your kidney. This aldosterone will go to your kidney and it will do what? Sodium and water retention. It is going to do what? Sodium and water retention. In which part of the kidney? In upper part of collecting duct. In upper part of the collecting duct, it is going to go, and it is going to do the formation of which channels? It is going to make the E-neck channel, the epithelial sodium channel, and these sodium channels are going to do what? Sodium and water retention. It is responsible for the retention of sodium as well as your water. So this is responsible for the sodium and water retention. Second layer we have got, which are, this is going to be zona fasciculata. Zona fasciculata is going to release what? Glucocorticoids. This is going to release what? Glucocorticoids, like your cortisol. And this cortisol has got some anti-inflammatory properties. This cortisol has got anti-inflammatory properties, right? This is the internal steroid of the body, and remember, this is a hormone which is going to cause increase in the glucose level. This is going to cause increase in the glucose level. This is a diabetogenic hormone. This is a diabetogenic hormone. This is what they have asked you, which is a diabetogenic hormone. One of them is going to be what? Cortisol is a diabetogenic hormone. Reticularis is going to release what? Dihydroepiandrostenediones. These are the DHEAs, which are the androgens which we are having, are going to be responsible for the growth, right? Then we have got this medulla. This medulla is going to release what? Catecholamines. Catecholamines like epinephrine, norepinephrine, and dopamine. These are the important catecholamines that we are having from the adrenal medulla. If you are having tumor of this adrenal medulla, this is known as pheochromocytoma. This is known as pheochromocytoma, where you will be having which appearance on MRI? This is going to be light bulb appearance on MRI. This is going to be pheochromocytoma. You can check for the levels of metanephrines. You can check for the pheochromocytoma. This is going to be the tumor of adrenal medulla, tumor. And when you are going to do the operation, you can use the drugs like phentolamine. You can also use drugs like phenoxybenzamine. To maintain the preoperative and intraoperative hypertension, we can give the drugs like phentolamine and phenoxybenzamine, right? So in this particular case, if they ask you, this is going to be the thing which is going to come from this particular point A. This is going to be your aldosterone. Adrenaline, we have already learned about adrenaline. Alpha 1, alpha 2, beta 1, beta 2, beta 3 activity will be there, right? Cortisol is an anti-inflammatory hormone. This is also known as internal steroid of the body. This is the internal steroid of the body, which is also considered as the glucocorticoids. This one is considered as the mineralocorticoids. And this antidiuretic hormone, the another name for this particular one is vasopressin, which has also got 3 receptor: V1 receptor, V2 receptor, V3 receptor. Right? This vasopressin has got V1, V2, and V3 receptor. V1 is going to cause vasoconstriction. V2 is going to be present in your aquaporins, responsible for water intake in the body, right? And third, V3 is going to be responsible for the release of adrenocorticotropin hormone, ACTH, right? These are the ADH hormone that we are having, right? The next one we have got is about the 23-year-old female patient is presented to OPD with the symptoms of fatigue. Patient is having what? Fatigue is there. Patient is having what? Pallor is there, and weakness is there. And she has no neurological deficit. She has got no neurological deficit is noted. On further examination, you are also finding what? Koilonychia. What is this koilonychia, beta? Koilonychia क्या होता है? What is this koilonychia? Koilonychia means spoon-shaped nail. Koilonychia means spoon shaped nail, right? And doctor has advised the iron therapy. Doctor has advised the iron therapy. Which of the following enzyme is responsible for conversion of ferric to ferrous from duodenal mucosa? Very, very important question. They can ask you definitely one question from iron absorption. They will be asking somewhat some question they will be asking you. Iron is very, very important. Iron transporter is very, very important, right? So how this thing is going to happen? What is your answer? Everyone is answering B, hepcidin. Read the question carefully, bache. Which of the following enzyme is responsible for conversion of ferric to ferrous in the duodenal mucosa? First of all, we need to understand what is ferric, what is ferrous. Ferric is the form which is Fe3 plus. Ferric is the form which is Fe3 plus. Fe2 plus is known as what? Ferrous. Fe2 plus is known as what? Ferrous. ध्यान रखो बच्चे, C से याद रखो, C for 3. A, B, C is the third thing. So C is going to be Fe3. Okay. Just give me 5 minutes and you will understand this. Fe3 is going to be what? Ferric. Ferric is going to be what? Fe3. ये यहाँ तक कोई issue नहीं है. Let's try to understand. Chalo. Someone has given me the right answer. Hela. Almas, right? Almas has given the right answer. So let's try to understand. Let me orient you. First of all, this is going to be what? Mucosa. Here you see your food. Whatever food you are eating is going to be here. This is going to be your epithelial cells that we are having, and this is going to be your submucosa where you will be having what? Blood vessels. This is the basic thing we are having. Food is going to be here itself. Now what is going to happen with that food? Let's try to understand. This food that you are eating, remember the food that we are eating will be having what? Food iron will be what? Food iron will be ferric form. Food iron will be in which form? Ferric form, right? इसकी कहानी देखते हैं. Let's try to understand the story of this ferric, from where it is going to start and from where it is going to go. Hepcidin is not the answer. Hepcidin is not the correct answer, beta. Hepcidin सबका answer नहीं होता है ना. Hepcidin is the wrong answer we are having. So let's try to understand this. So first of all, whatever iron that you are eating, that iron will be present in the Fe3 plus form. The iron that you are eating is going to be present in the Fe3 plus form. So this iron will be converting. This iron will be converting in the duodenum with the help of duodenal cytochrome B. What is the name of this enzyme? 5 minutes and you will understand this, right? So whatever iron that you are eating, food iron, I'm not teaching you about the heme iron, that is a biochemistry part. I'm teaching you about the food iron that you are eating is going to go in which form? It is going to go in the Fe3 plus form. Why? What is going to happen with that Fe3 plus? Why we need to convert this Fe3 plus into Fe2 plus? Because we are having only entry. Entry किसको मिलेगा? सिर्फ 3 लोगों को entry नहीं है, सिर्फ couple entry है. Okay, double people can go inside, right? So you will be having double people entry, no 3 people are allowed, right? So what is going to happen? This Fe3 plus needs to convert into Fe2 plus first. Okay, and this conversion is happening with the help of which enzyme? This process is known as what? Reduction. This process is known as reduction. This is going to be the reduction that is going to happen with the help of duodenal cytochrome B enzyme. Duodenal cytochrome B is going to do what? Fe3 plus will be converted into Fe2 plus, right? This is the first thing. It will also tell you about the site of absorption of iron. The site for absorption of iron is going to be what? It is going to be what? Duodenum. It is going to be what? Which is duodenum, right? Second question they can ask you. Everything is a question from here, right? Second question they can ask you, once it will convert into Fe2 plus, another question they have asked you is about how it is going to enter into duodenal cells with the help of DMT1. What is this DMT1? It is also known as divalent metal transport. Divalent metal transport. So you can easily understand it will only allow the passage of what? Fe3 plus or Fe2 plus. Divalent means only 2 valency people can go inside, only couple will go inside, right? So when this Fe2 plus will go inside, it can either store in the body, in the duodenum, in the form of what? In the form of mucosal ferritin. Either it can store in the form of mucosal ferritin, either it can go where? Either it can go back, right? Where it will be going? It will be going back to the blood vessel, right? It will be going back, and it will be going back to the blood vessel, right? What will happen here? You will be having another pump, another channel, another gate will be there, and the name of this gate is going to be ferroportin. Ferro means iron, port, this is responsible for the entry of iron. This is going to be ferroportin. तो यहाँ पर कौन सा आयरन आएगा बेटा? फिर से this is going to be Fe2 plus, this is going to be again Fe2 plus. Okay, I will try to connect it with other things also. Okay, this is also Fe2 plus which is going to be coming here. Now this Fe2 plus cannot travel in the body, है ना, ये Fe2 plus travel नहीं करेगा अकेला. So what we need to do, we need to again convert it into Fe3 plus, right? वापस से क्या बनाना है? फेरस के फेरिक, वापस से फेरिक बनाना है. We need to make it ferric again, right? So how we are going to make it ferric again? With the help of another enzyme. This is the hephaestin we are having. This is the hephaestin enzyme that we are having. What is the function of hephaestin? To convert Fe2 plus into Fe2 plus. ये इस side होगा, right? This is going to be on this particular side, right? And now this Fe3 plus cannot travel alone. Fe3 plus will require the Gadi. What is the Gadi we are having? What is the cap we are having? The cap that it will require is going to be the iron transporter, and this is going to be transporter for iron, transporter for ferrin. This is going to be transferrin beta. This is going to be transferrin, which is also known as iron transporter. Now iron को कहाँ transport करना है? Where we need to give iron? To the bone, to the bones, or to the marrow, more specifically to the bone marrow, right? So erythroid bone marrow, this is going to make what? This is responsible for the formation of what? Hemoglobin. So whatever iron we are eating is going to make what? Hemoglobin, and that is how we are not having what? Iron deficiency anemia. अगर किसी के अंदर आयरन नहीं है तो क्या होगा? आयरन डेफिशिएंसी एनीमिया हो जाएगा. बात समझ में आ रही है, राइट? यू अंडरस्टैंड दिस. Second thing, when you have enough iron in the bone marrow, what is going to happen? Some iron will go to the liver. Some iron will go to the liver, and now this liver will be releasing this hepcidin that you have been marking. ये गलत आंसर था, है ना? hepcidin नहीं होगा. This hepcidin will be released from the liver, and this is the hepcidin beta which is going to act as a brake. Hepcidin is going to act as a brake. What is the function of hepcidin? It is going to act as a brake. किसके ऊपर ब्रेक है? फेरोपोर्टिन के ऊपर ब्रेक है. बहुत ही इंपॉर्टेंट साइकिल है, राइट? यू अंडरस्टैंड? तो ब्रेक कब लगेगा? एंड में लगेगा. डेफिनेटली वन क्वेश्चन विल बी देयर, राइट, फ्रॉम दिस पर्टिकुलर साइकिल, राइट? Let me summarize it for you. Whatever food iron that you are eating, this is going to be the mucosa. These are your villi, whatever is there. This is the food iron that you are eating. This is going to be your epithelium cell. This is going to be what? This is going to be the blood vessel that we are having. इधर क्या है? blood vessel है. This is the blood vessel. This is the mucosa where you are having food. And this food iron that we are eating is going to be ferric form. Ferric से क्या याद रखना है बेटा? C होता है. C से C याद रखना है. It is going to be Fe3 plus. Fe2 plus is going to be which form? Ferrous. Ferrous होगा. Fe2 is ferrous. We are eating iron in which form? We are eating in the Fe3 plus. It will be converting. Conversion is with the help of question number 1. Conversion is with the help of duodenal cytochrome B. Duodenum cytochrome B. Second thing, when it will convert into Fe2 plus, it can go and enter inside with the help of divalent metal transport. More specifically, divalent metal transport 1 is the answer. है ना? ऑप्शन में 2 भी दिया हुआ था, right? So DMT1 is going to be the answer for this particular one, right? DMT1. And when it will go inside, it will store in the form of mucosal ferritin. It can come out in the ferroportin. This is going to be ferroportin. Now Fe2 plus needs to convert into Fe3 plus with the help of hephaestin. With the help of hephaestin, and this iron will be traveling with the help of transferrin, and this iron can go back into the cell also. Liver, right? It can go back into the liver also. What is the brake for iron? This is going to be known as hepcidin. What is the brake for iron, bacha? Brake for iron is known as hepcidin. अब सोचो, if you are having this mutation of this hepcidin, what is going to happen? Hepcidin mutation will lead to what? Hepcidin mutation will lead to what? अगर ब्रेक फेल हो गया, what will happen? You will be having lots and lots of iron. This disease is known as iron overload disease, also known as what is the another name for this particular disease? This is also known as hemochromatosis, where this iron is deposited in the liver, causing what? Liver cirrhosis. Excess of iron deposition on liver will cause liver cirrhosis. If the same iron will go to the pancreas, it can cause what? Diabetes. It can cause what? Diabetes. What kind of diabetes? Skin color will also change. This is going to be bronze diabetes. This is going to be bronze diabetes. We can have skin color will be changing. You will be having what? Hyperpigmentation will be there. Right? This is going to be the things you will be having in the hepcidin mutation, or you can also remember HFE gene mutation. HFE gene mutation, hepcidin mutation is going to cause what? This particular thing. Now I ask you 4 simple questions. What is the eating form of iron? What is the eating form of iron that we are eating? What is the iron? Food iron is going to be what? First answer will be ferrous. Second question is how it is getting converted from ferrous to ferric with the help of what? Duodenal cytochrome B. This is the second question. What is the site for iron absorption? This is the third question. Duodenum is the site for iron absorption. Once it will absorb, now what is going to happen? It will enter into the cell. It will enter into the duodenal cells, epithelial cells, with the help of what? With the help of divalent metal transport 1. DMT1 is responsible. Fourth question. Fifth question, you can have storage in the form of what? Storage form of iron is going to be what? Ferritin. Storage form is ferritin. Entry into blood is going to be what? With the help of ferroportin. Ferroportin. Conversion of Fe2 plus, or they can also write you ferrous to ferric in the blood, is going to be with the help of hephaestin. Hephaestin. What is the transporter of iron? This is another question. Ninth question. This is going to be what? Transferrin. 10th question. What is going to be the function of this iron? It is going to make what? Bone marrow. It is going to make what? Blood cells in the bone marrow. What is going to be the break? This is going to be what? Hepcidin. 10th question. 11th question, they can ask you what will happen if there is a break failure or HFE gene mutation or hepcidin mutation. You can have iron overload in the body, you can have hemochromatosis, you can have liver cirrhosis. This iron will deposit extra iron on the liver. This iron can deposit in your beta cells of pancreas, leading to what? Bronze diabetes. You can have hyperpigmentation. Very, very important, definite question from this particular thing. Okay, now try to mark the answer. Now you can understand all the 4 terms that we are having, right? All the 4 terms, I hope crystal clear to each one of you. This is going to be hephaestin, this is hepcidin, this is DMT, this is duodenal cytochrome B. All these questions they have asked, right? So what is the question they want to know? Ferric to ferrous in duodenal mucosa. This is how you can also read the question. If you have good concept, you can understand. Ferric to ferrous is going to happen because of what? Is it hepcidin? Is it hephaestin? Is it DMT? Is it duodenal cytochrome B? Now you can mark the answer with confidence. This is going to be definitely, sir, duodenal cytochrome B is going to be the answer. Okay, no issues with this. Give me a quick confirmation. No issues with this, so that we can move forward. Just try to read the another question. Given below is the oxygen hemoglobin dissociation graph showing the right shift of the graph. All of the following can be associated with the hypoxia except associated with this except. So, all right. All right, try to solve this question. Right shift of the graph is due to. Simple question. Right shift of the graph is due to what? Due to hypoxia? Is it due to acidosis? Is it due to reduced in affinity? Is it due to alkalosis? This type of question, if you use your common sense, what is the common sense? Sir, hypoxia and reduced affinity are cut it, right? Because the 2 options are contradictory. These are acidosis and alkalosis. तो आंसर तो इसमें से होगा कुछ ना कुछ, right? ऐसा कुछ क्वेश्चन है. ऑल ऑफ द फॉलोइंग कैन बी एसोसिएटेड विद दिस एक्सेप्ट. तो 3 तो एसोसिएटेड होंगे, एक नहीं होगा, राइट? दे वांट टू नो अबाउट व्हाट, व्हिच वन इज नॉट एसोसिएटेड, right? So what you can suspect? You can suspect that 2 options are contradictory. These are acidosis or alkalosis. दोनों में से एक आंसर होगा, दोनों तो साथ में होंगे नहीं, right? So you can remember hypoxia, you can remember reduced affinity. Now you have only 50-50. Try to answer. Try to answer this one. So let me make you understand how this thing is going to take place. Let's try to understand this, right? So we have got what? We have got this graph. This graph is known as hemoglobin oxygen dissociation curve. This graph is known as hemoglobin oxygen dissociation graph. This graph is known as hemoglobin oxygen dissociation graph, where we are going to learn how this hemoglobin is dissociated from the oxygen. This is a classical question they are asking from the physiology, right? Every time they are asking this question, because you are learning these things with the help of mnemonics, and then you will forget it, right? In the examination you will be making mistakes because you will forget the mnemonic. So let's try to make some concept around it, and let's try to understand this with the help of some concept, so that you will not be able to forget this, right? Let's try to understand. So what is this hemoglobin and oxygen? Sir, this is a basic thing we are having. Hemoglobin as a function to transport the oxygen. Yes or no? हीमोग्लोबिन का फंक्शन क्या होता है? व्हाट इज द फंक्शन ऑफ हीमोग्लोबिन? टू ट्रांसपोर्ट द ऑक्सीजन टू डिफरेंट सेल्स वेरेवर इट इज रिक्वायर्ड, राइट? सो दिस इज एच बी कहानी, ये कहानी है हीमोग्लोबिन ऑक्सीजन की. एंड व्हाट इज गोइंग टू हैपन, यहाँ पर इस कहानी में क्या होगा? यहाँ पर reduced in affinity. एक word याद रखने, the only word you need to remember, in the right shift you will be having reduced in affinity. Affinity means love. Affinity means love. So when you are going to have decrease in the love, when you are going to have decrease in the affinity, कब होगा decrease in affinity? When you have what? Hypoxia. इनका breakup कब होगा? When we are going to have the breakup, hemoglobin plus oxygen breakup is going to take place when you have what? When you have hypoxia. जब आपको ऑक्सीजन की ज़रूरत पड़ेगी तभी तो एक ऑक्सीजन छूट के आएगा, तभी तो हीमोग्लोबिन इस ऑक्सीजन को छोड़ेगा, राइट? दिस इज व्हाट इज द हाइपोक्सिया वी आर गोइंग टू हैव, राइट? और जब भी हाइपोक्सिया होगा बेटा, जब भी हाइपोक्सिया होगा तो क्या मैं कह सकता हूं कि CO2 का लेवल, हाइपोक्सिया होगा तो ऑक्सीजन का लेवल क्या कम हो जाएगा? यस, दिस इज व्हाट इज नोन एज हाइपोक्सिया. और अगर हाइपोक्सिया हो गया तो क्या CO2 का लेवल बढ़ जाएगा? यस, CO2 का लेवल बढ़ जाएगा. दिस इज गोइंग टू बी द इंक्रीजिंग, राइट? सो व्हेनेवर यू आर हैविंग हाइपोक्सिया और व्हेनेवर यू आर हैविंग मोर ऑफ CO2, what will happen? This is going to cause right shift of the graph. Right shift means breakdown will be there. Right shift means breakdown will be there. Increase in CO2. Who is the brother of CO2? Always remember, जब भी CO2 बढ़ेगा क्या बढ़ जाएगा बेटा? H प्लस बढ़ेगा. जब भी CO2 कम हो जाएगा क्या हो जाएगा? H प्लस कम हो जाएगा. सो दीज आर गोइंग टू बी ब्रदर्स फॉर लाइफ, है ना? ये दोनों क्या है? भाई भाई है, ये दोनों हमेशा साथ में चलेंगे. CO2 इंक्रीज लीडिंग टू व्हाट? इंक्रीज इन द लेवल ऑफ H plus. Increase in H plus is also known as what? Alkalosis or acidosis? Increase in H plus is going to be what? What happens to the pH? Increase in H plus means acidosis or alkalosis. Increase in H plus means what is going to be there? It is going to cause acidosis. H plus बढ़ जाएगा तो क्या हो जाएगा? Acidosis हो जाएगा, right? CO2 बढ़ जाएगा तो क्या हो जाएगा? Acidosis हो जाएगा, right? This is going to be the acidosis that we are going to have. And acidosis means what is going to happen with the pH? What is going to happen with the pH in acidosis? You will be having increase in pH or decrease in pH. pH कितना होता है? pH कम की तरफ हो जाएगा. 1 2 3 4 like pH will be there, right? This is going to be, pH will be decreased, right? So they can ask you anything. You will be having decrease in the pH, you will be having increase in the H plus. You can they can tell you increase in the temperature. रिमेंबर बेटा, जब आप टेम्परेचर बढ़ाओगे तो क्या ब्रेकडाउन बढ़ जाएगा, इनका प्यार टूटेगा? यस, टेम्परेचर बढ़ेगा तो हीमोग्लोबिन ऑक्सीजन टूट जाएगा. ऑब्वियस सी बात है, व्हेनेवर यू आर गोइंग टू इंक्रीज द टेम्परेचर एवरीथिंग विल बी ब्रोकन. दिस इज गोइंग टू इंक्रीज व्हाट? Increase in temperature. So simply no need to mug up anything, just remember simple funda. What is the simple funda? Hemoglobin oxygen की कहानी है. When this hemoglobin is released or when this breakup is going to happen, whenever there is requirement. And when is going to be the requirement? Whenever there is increase in CO2. Increase in CO2 means increase in H plus. Increase in H plus means acidosis. Acidosis means decrease in pH, and decrease in pH means increase or you can also remember increase in the temperature will also do this particular thing, right? So what is going to be the answer here? यहाँ पर reduced affinity था या increased affinity था? Okay, let me make you understand the another part, counter part. ये क्या हो गया? Right shift of the graph. This is going to be right shift of the graph. In right shift, you need to remember what is the effect that is going to be, we calling it, this effect is known as Bohr effect. This effect is known as Bohr effect. This right shift is known as Bohr effect. What is left shift? What is left shift? Left shift में क्या होगा? Now they are tightly packed. Now they are tightly packed. इनका प्यार बढ़ गया, इनका affinity बढ़ गया. Here you will be having reduced affinity or increased affinity. Increase in the affinity, increase in the love is going to be there. And if there is increase in the love, what is going to happen? Are they going to do the breakup? There will be no breakup. If there will be no breakup means what? You will be already having what? Good amount of oxygen. That means what is low? What is low? CO2 will be low. And if CO2 will be low, you can easily understand what is going to be low. H plus will be low. And if H plus will be low, what do we call it? We call it acidosis or alkalosis. We call it alkalosis. And what will happen in alkalosis? pH will be increased. There will be increase in the pH and there will be decrease in the temperature also. Right? So this is going to be the left shift of the graph. This is going to be the left shift of the graph. What you need to remember, left shift is known as Haldane effect. Haldane effect. Right? Whereas this right shift is known as Bohr effect. Bohr effect. Right? Simple. Hai? Right? Now just try to answer this question. Right shift, they want to ask you right shift. Right shift means what is going to happen? Reduced in affinity. Reduced in affinity means what is going to happen? You will be having hypoxia. Yes. Hypoxia means what is going to happen? Reduced affinity will lead to hypoxia. Hypoxia will lead to increase in the hypoxia की वजह से क्या होगा? You will be having increase in the CO2, increase in the H plus. Increase in the H plus is known as acidosis. So all these three things can be there. What is not going to be there? This is going to be alkalosis. This is going to be the answer in this particular case. Very good, guys. Very good. Okay. Next one we have got, in the given spirogram, the point E is indicating about. In the given spirogram, the point E is indicating about. यहाँ पर point E क्या बता रहा है? You need to answer this. This is the point E that we are having. It is going to tell us about what? This point E is telling us about what? This point E is telling us about what? Is it going to tell us about FRC, functional residual capacity? Is it going to tell us about the RV, residual volume? Is it going to tell us about the ERV? Is it going to tell us about the VC, vital capacity? It's very simple. It is very, very simple. So let me make you understand what are the volumes we are having, what are the capacities we are having, है ना? फटाफट से करते हैं इसको. What are the volumes we are having, what are the capacities we are having? These are the volumes that we are having. These are the capacities that we are having. So we have got two things. One is the volume, another one is the capacity, right? So volume कितने तरीके के होंगे? First volume that we are having is known as tidal volume. So just look at this particular graph. Tidal volume is the volume that you are inhaling, that you are expiring or inhaling with a normal tidal volume that we call it. Normal inspiration, normal expiration. What is the volume of air that you are inhaling? This is known as normal tidal volume. This is going to be what? 500 ml. This is going to be 500 ml. This is going to be normal tidal volume that we are having, 500 ml. Right? What is IRV? Inspiratory reserve volume beta. Inspiratory reserve volume is going to be what? The volume that you can inhale with the maximum inspiration. है ना? So this is going to be the volume with the maximum inspiration. From this particular point, this is the maximally that you can inhale. This is known as inspiratory reserve volume. This is known as what बच्चे? Inspiratory reserve volume. एक बार समझ में आ गया? क्वेश्चन गलत नहीं होगा, right? So this is going to be what? Inspiratory reserve volume. Third one we have got is expiratory reserve volume. The maximum expiration that you can do, है ना? Like that. The maximum expiration that you can do. This is going to be expiratory reserve volume. And lastly, you have got what? Residual volume. So this is the residual volume, which is the volume of lungs which you cannot measure normally. For example, let me give you one example. Like you bought balloon right? You bought balloons, right? In balloons, once you inflate a balloon, there will be always some amount of air will always be there. This amount of air you cannot change, you cannot make it out, you cannot bring it out, right? This is going to be the volume. This is known as residual volume. So we have got these four volumes. What are the four volumes? मैं mnemonic दूंगा, तुमको याद हो जाएगा, right? So what are the four volumes? First, understand the four volumes. Tidal volume, IRV, ERV, RV. Tidal volume is the normal volume. Inspiratory reserve, maximum inspiration. Expiratory reserve, maximum expiration. And residual volume is the volume which is going to be retaining there. अब होती है capacities. चार capacities याद रखने हैं, four capacities. फर्स्ट वन इज योर इंस्पिरेटरी कैपेसिटी. इंस्पिरेटरी कैपेसिटी मतलब क्या हो गया बेटा? वॉल्यूम में हमने सिंगल लिया था. अब इंस्पिरेटरी कैपेसिटी मतलब टाइडल वॉल्यूम प्लस इंस्पिरेटरी रिजर्व वॉल्यूम. दिस इज नॉन एज व्हाट? दिस इज नॉन एज इंस्पिरेटरी कैपेसिटी. ऐसे ही एक्सपिरेटरी कैपेसिटी हो जाएगा. एक्सपिरेटरी कैपेसिटी मतलब टाइडल वॉल्यूम प्लस maximum expiration that you are doing. This is going to become expiratory capacity. Vital capacity is going to be maximum inspiration, maximum expiration, and this maximum expiration along with the tidal volume. So यहाँ से लेकर यहाँ तक का जो है, this is going to become what? Tidal volume. Maximum, look here, this is the tidal volume, this is known as tidal volume. This is your maximum inspiration, this is your maximum expiration, and this complete entity will become what? This complete entity will become vital capacity, which is having inspiratory reserve volume, tidal volume, and expiratory reserve volume. What is FRC? This is important. This FRC will be having two volumes. Functional residual capacity, it is something having two volumes. One is going to be residual volume, another one is expiratory reserve volume, right? And lastly, we have got what? Total lung capacity. This is going to be 6 liter. Okay, now let me give you the mnemonic. What is the mnemonic? How you can remember this? This is going to be your RETI TVI. Just try to understand this. Once you will try to identify how to make this, you will be having very ease while solving the question. This is going to be RETI TVI, right? Remember, these are going to be the four volumes that we are having. Now you will be telling me what are the volumes we are having. First volume is the residual volume. This is going to be RV. This is known as residual volume. Second is expiratory reserve volume. This is the maximum expiration. Third is going to be tidal volume, beta, 500 ml, normal tidal inspiration expiration, and I is equal to inspiratory reserve volume. That is the maximum inspiration that we are having. This is going to be the maximum inspiration, tidal volume, expiratory reserve volume, and lastly we have got RV. यहाँ पर लिखेंगे बेटा कैपेसिटी, यहाँ लिखेंगे हम लोग कैपेसिटीज. सो वी हैव गॉट total lung capacity, TLC, we have got vital capacity, we have got inspiratory capacity, right? How to remember them? Just remember, now we are done. Residual volume plus ERV is going to make what? Functional residual capacity. Residual volume plus ERV, this is your residual volume plus maximum expiration. This is going to become what? These two are going to make what, bache? These two are going to make FRC. This is known as functional residual capacity, functional residual capacity, right? Then this ERV and this TV, expiratory reserve volume, maximum expiration plus tidal volume. This is going to become what? This is going to be expiratory capacity, expiratory capacity. This is going to be expiratory capacity. You can check tidal volume plus ERV is known as expiratory capacity. And lastly, we have got what? Now you can make it simple. Tidal volume plus IRV is going to become what? Inspiratory capacity. Tidal volume is the normal respiration. IRV means maximum inspiration. Maximum inspiration plus tidal volume, inspiratory capacity. Maximum inspiration, tidal volume plus maximum expiration. This is known as what? This is known as vital capacity. This is known as vital capacity. Tidal volume, this is normal inspiration. Maximum inspiration, maximum expiration, this is going to become what? Vital capacity. And when I'm going to combine all of them together, this is going to become what? Total lung capacity. Once you make it, you will be having it with you. This is going to be RETI TVI. This is going to be RETI TVI. You will be able to solve the question, because in exam they will be asking you what is VC, what is IC, what is FRC, what is TLC, and you will be getting confused over there, right? So this type of question, we are not going to make anything wrong. Okay, now you will be telling me one by one, what is this first one? Wherever you are, just try to identify it and answer. What is the first one we are having? The first one is tidal volume, beta. Second one, this is going to be what? Maximum inspiration. Maximum inspiration is known as inspiratory reserve volume, right? This is going to be what? C point is going to be maximum expiration. Maximum expiration is known as what? Expiratory reserve volume. And whatever is there is going to be become what? That you cannot touch. This is going to become what? Residual volume. This is going to be the E point, right? And then what is D? This is going to have tidal volume plus inspiratory volume. This is going to become what? Tidal plus inspiratory is going to become what? Tidal volume plus inspiratory is going to become what? Inspiratory capacity. This is inspiratory capacity, right? The next one we have got is these two expiratory reserve volume plus RV plus ERV. This is going to become what? Functional residual capacity. And if you want to talk about this particular one where you will be having all these three things together, this is going to become what? Vital capacity, and all of them are going to become what? Total lung capacity. Simple है ना, right? Just go through this particular thing. देखो ये कुछ questions है जो definitely they are going to ask you, बार बार repeat होते हैं. Oxygen hemoglobin dissociation curve, this pyrometry वाला question है ना, वो pressure volume graph वाला question. These are the questions which are going to come again and again. Okay, primary active, secondary active, transport पे question पूछ लेंगे. So they are going to be fixed type of question they will be asking you, right? In this particular case, the answer is going to be what? Residual volume, which is going to be the point E. I hope you understood this. Now, which of the following point correspond to depolarization of the right atrium? Now you gotta answer me, which of the following point is responsible for the depolarization of the right atrium? Right atrium का depolarization किसकी वजह से हो रहा है? Okay. How many says A, B, C, D? Try to answer. E. Let me make you understand this also. So we have got what? We have got 4 chambers in the heart, and this is known as what? This is known as, we have got 4 chambers in the heart, and this is known as what? This is the thing we are having. This is known as JVP. This is your right atrium, this is your right ventricle, left atrium, left ventricle. Okay beta, this right atrium story is told by this particular thing. This is known as JVP, jugular venous pressure. This is known as JVP. This graph is known as JVP, right? This graph is known as what, bacha? JVP. So what is going to happen? How this graph is formed? Let's try to understand this, right? I've told you first wave is going to be the A wave that we are having, and this A wave is going to tell us about the atrial systole. A wave is going to tell us about the atrial systole. When, just try to understand this, when your atrias are contracting, where your atrias, it is the only thing, JVP is only thinking about this right atrium. JVP is only going to tell you something about right atrium, nothing else, है ना? JVP जो भी बताएगा सिर्फ और सिर्फ right atrium के बारे में बताएगा, right? So this is going to be the right atrium condition, and this is going to be the JVP, right? So A is going to tell us about the systole. This is going to tell us about the systole. So when atrias are going to contract, the blood will go to the ventricles. So when atrias are going to contract, you will be having a rise in pressure. This is known as A wave. This is known as A wave, and this is going to tell us about the atrial systole. What is the C wave? This C wave that you are finding, it is due to bulging of tricuspid valve. यहाँ पर कौन सा valve बताया था बेटा? Tricuspid valve. So now this tricuspid valve will bulge into right atrium during isovolumic contraction. I told you isovolumic contraction is the phase, right, where you will be having isovolumic contraction. You will be having what? You will be having bulging of tricuspid valve into right atrium. Bulging of tricuspid valve into right atrium, this is known as isovolumic contraction, and because of that bulging you will be having this small C wave. This is going to be the small C wave that you are going to have. This is going to be due to bulging of right atrium, bulging of tricuspid valve into right atrium. ये C wave आ गया. Then you will be having what? Then you will be having decrease in the pressure. This C wave is going to be because of bulging of tricuspid valve into right atrium, and this is also happening during isovolumic contraction. This is your previous year question, they have asked this particular question. This is a previous year question they have asked, right? Then you will be having X wave, then you will be having which wave, which descent. X is the descent, so you will be having X descent, right? X is due to relaxation. X is due to relaxation of right atrium, because I told you we are always discussing about the right atrium, right? So now this, because now what is going to happen after bulging, what should be happening? Just try to understand, the bulging should be happening here and here also, and after bulging what should be happening? You will be having an opening of these valves, right? And because of opening of these valves, what is going to happen? You will be having relaxation, and this relaxation is explained by the X wave. This relaxation is explained by the X wave, right? Relax, X is going to relax, है ना? X को relax करा देना, right? And then you will be having what? Then you will be having this V wave. This V wave is due to what? This V wave is due to filling. This V wave is due to filling. This V wave is due to filling. Why this filling is happening? And now after relaxation, what is going to happen? You will be having chamber will be closed, right? This chamber will be closed, and this chamber will be having isovolumic relaxation should be happening, right? So before isovolumic relaxation, here you will be having blood coming. So what is going to happen? You will have again one wave coming. This is known as V wave, and this V wave is going to tell us about the filling. This V wave is telling us about the filling of blood in right atrium. And then what is going to happen? This, after this filling, you will be having what? You will be having opening of which valve? Opening of tricuspid, opening of bicuspid valve, leading to what? Leading to decrease in the pressure. ये सारा blood कहाँ जाएगा? ऊपर से नीचे आ जाएगा. This is known as Y wave, and this Y descent. This is also descent. Two descent we are having, right? This Y is telling us about the emptying. Y is going to tell us about the emptying of right atrium. Emptying of right atrium. This is going to be told us about by the Y wave. So this is going to be Y descent. Two descent will be there, Y descent and X descent, X and Y descent, and three waves, A wave, C wave, and V wave. So if you can understand this, well, good. If you don't understand it, just remember these points. A is responsible for the systole. A wave is for the systole. C for bulging of tricuspid valve into right atrium during isovolumic contraction. X for relax. X is for the relax. V is for the filling. V is for the filling, and Y is for the emptying. Beta. Y is for the emptying. Y for Y याद रख लो, that is the emptying. X for X, that is the relax. V for filling याद रखना है. A for systole, and B, C, you can also remember isovolumic contraction that we are going to have, right? This is the basic funda we are having. Like these are the things where else you will study about JVP in cardiac tamponade. Can anyone tell me what will happen in cardiac tamponade? What is the triad that you will be finding? You will find a triad. That triad is known as backstride beta. So what is going to happen in backstride? Just understand this thing. Outside the heart, you will be having which cavity? You will be having this particular thing. You will be having this pericardium, and in this pericardium, what is going to be there? You will be having lots and lots of fluid accumulation. This is known as what? बहुत सारा fluid accumulate हो जाएगा. This is known as what? This is going to become what? Cardiac tamponade, right? So what is going to happen in cardiac tamponade? If you are going to put your stethoscope over here, what is going to happen? Are you able to hear the sounds? No, you cannot, right? You cannot. You can hear the sounds, but not so good. This is going to be known as muffled heart sound. This is going to be the muffled heart sound. Second thing, what is going to be there? You will be having what? Elevated JVP. Why elevated JVP? Because you will be having more pressure here in left ventricle and right ventricle, leading to what? More pressure in the right atrium, and this right atrium pressure will lead to what? Raise the JVP. Third thing, you will be having what? Hypotension beta. Why hypotension? Because this left ventricle is not able to contract well. This left ventricle is not able to contract well, leading to what? Decrease in the supply of the blood, also decrease in the contraction, leading to what? Hypotension. This stride is known as what? Back stride. This stride is known as what? Back stride. Hypotension, elevated JVP, muffled heart sound. You can simply understand पानी भर गया heart के बाहर. Okay, what kind of ECGs you will be finding? High amplitude ECGs or low voltage ECGs you will be finding. Remember beta, ECGs are also going to be low voltage. क्यों होगी low voltage? पानी भरा है बाहर. Your machine could not assess the current, right? Well, so you will be having low voltage ECG over here, right? These are the important findings we are having in this particular case. So what is going to be your answer now? They are asking about the depolarization. Depolarization मतलब systole होता है क्या? Yes, depolarization you can also understand with the systole, also understand with the contraction. So answer in this particular case is going to be which wave now? The answer will be A wave. Answer will be A wave. So this is going to be the A wave that we are having, telling us about the systole. देखो दो तरीके इसके क्वेश्चन आते हैं, दो तरीका, या तो समझ लो या याद कर लो, राइट? सो अगर समझ में नहीं आया तो याद कर लो. We can understand these things and it requires time to make you understand, right? The same thing is written. E wave is telling us about the atrial systole. C wave is telling us about the bulging of tricuspid valve into right atrium during isovolumic contraction. X is going to tell us about the fall in right atrial pressure due to relaxation. V is going to tell us about the right atrial filling, and Y is going to tell us about the rapid emptying due to opening of the tricuspid valve. Okay, this is what is the thing we are having. Same thing. Next question we are having, which of the following receptors are present in beta cells? Okay, beta cells for the uptake of glucose, and also identify the insulin dependent glut receptor. What are the insulin dependent glut receptor we are having? Let's try to understand this, right? Try to answer this. Then I will summarize diabetes for you. Which of the following receptors are present in beta cells? Beta cells में कौन सा receptor होता है? For the uptake of glucose, and also identify the insulin dependent glut receptor. What are the insulin dependent glut receptor? कौन से होते हैं? Present in the skeletal muscle. है ना, एक कहानी सुनाऊंगा तुमको याद हो जाएगा, right? What is the story we are having? This is a story of momos, है ना, ये मोमो वाली कहानी है, right? So let's try to understand the story of momos, right? When you are eating momos, what is going to happen? आपने मोमोज खाया, आपके पेट में मोमो गया. What is going to happen with that momos, right? You will be having formation of glucose in the mucosa. Glucose formation will be there in submucosa. You will be having absorption. Blood vessels will be there, and this glucose will come into blood vessel. What is going to be this particular thing known as? This is known as hyperglycemia. This is known as hyperglyce means glucose, emia means in the blood. So you will be having hyperglycemia after eating what? Carbohydrate. You will be having what बच्चे? Hyperglycemia. Now this blood is a connective tissue बेटा. Blood a connective tissue होता है, हमने पढ़ा था, right? Blood is a connective tissue. What is going to happen? This connective tissue is going to transport this glucose. This glucose will be transporting all around the body because blood is the connective tissue. It will go to your which cells also? It will go to your beta cells also. It will go to your which cells? Beta cells also, right? This is going to be your beta cells. And beta cells के पास में जब ग्लूकोज आएगा, remember glucose is a type of what kind of transport? SGLT, sorry, glut is a type of what kind of transport? Glut is a type of primary active, secondary active, facilitated diffusion or osmosis. Remember beta, this glut is a type of facilitated diffusion. So what is going to happen? This glucose is going to come inside. When this glucose is going to come inside, you will be having formation of glycolysis, right? Glycolysis होगा, and end product of glycolysis is going to be pyruvate, है ना? कितना ATP बनता है? 7 ATPs will be formed, right? And after formation of this ATP, what is going to happen? You will be having the ATP sensitive potassium channel. है ना। जब तक मैं ये बता रहा हूँ, जस्ट ट्राई टू राइट डाउन ऑल द ड्रग्स दैट यू नो, ऑल द ड्रग्स दैट यू नो अबाउट द डायबिटीज, राइट। हम लोग उसको भी समराइज कर लेंगे, राइट। एंड टाइम में you already revised all those things, right? Just we will summarize everything, right? So whatever glucose you are eating, that glucose will convert into pyruvate, and now what will happen, this ATP sensitive potassium channel will be there, and this ATP sensitive potassium channel will be closed beta. ये एटीपी सेंसिटिव पोटेशियम चैनल बंद हो जाएगा बिकॉज ऑफ द एटीपी प्रोडक्शन। और अगर कोई भी चैनल बंद हो गया ये, तो क्या होगा, पोटेशियम अंदर एक्यूमुलेट हो जाएगा। एंड वेन एवर अ पॉजिटिव चार्ज इज एक्यूमुलेटिंग इनसाइड अ सेल, दिस इज नॉन एज व्हाट बच्चे, this is known as depolarization. And because of that depolarization, what is going to happen, calcium will come inside, and calcium has got only three functions in life. Important three functions are going to be what, in muscle it is going to cause muscle contraction, in vessel it is going to cause vasoconstriction. Here important for us is going to be exocytosis, which is going to be a release of this insulin vesicle into the blood vessel, right? insulin कहाँ आ जाएगा बेटा, blood vessel में आ जाएगा। insulin is going to come into the blood vessel. Why in the blood, why in the blood vessel, why this insulin and this other things, what are the other things, we are having amylin, we are having C peptide, ये तीनों चीजें बाहर क्यों आई, beta cells will release all those things directly into the blood because this is the endocrine gland, and endocrine gland will release their substances directly into the blood vessel, directly into the blood vessel. This endocrine substances are going to come out into the blood vessel, and once you have got these endocrine substances into the blood vessel, what is going to happen, you will be having this insulin. Insulin is the key, right? Now what will happen with the key, this key will go to the cells, which cells, which are GLUT4, which are GLUT4 dependent. Which cells are going to be GLUT4 dependent, these are the cells which are dependent on what, these are the cells which are dependent on insulin. They are the insulin dependent cells. We can have skeletal muscle, we can have cardiac muscles, we have got adipocytes, right? So what is going to happen, this extra glucose hyperglycemia that we are having, now what is going to happen, this key which is coming out, we are going to take this key will come all the way and it will bind here, this key will come all the way and it will bind here, और देखो बेटा क्या हो जाएगा, ये चैनल खुल जाएगा, और खुलने की वजह से क्या होगा, इफ इट इज गोइंग टू ओपन, व्हाट इज गोइंग टू हैपन, दिस एक्स्ट्रा ग्लूकोज विल गो इनसाइड, ये एक्स्ट्रा ग्लूकोज अंदर चला जाएगा, ये एक्स्ट्रा ग्लूकोज एडिपोसाइट्स में चला जाएगा, इट विल स्टोर्ड इन द फॉर्म ऑफ एडिपोसाइट, इट विल यूटिलाइज इन द फॉर्म ऑफ एटीपीज इन द स्केलेटल मसल। कैसे यूटिलाइज होगा, दिस ग्लूकोज विल कन्वर्ट इनटू व्हाट, ग्लूकोज का क्या होगा, पहले ग्लाइकोलाइसिस होगा, this glycolysis, what is the site for glycolysis, the site for glycolysis is going to be mitochondria or something else. This is what is happening in the cytoplasm, right? It is happening in the cytoplasm, then it will enter into pyruvate, will enter into what, Krebs cycle, you will be having what, Krebs cycle beta. After Krebs cycle or TCA cycle, it will enter into electron transport chain, and this glucose will convert into H2 and H2O and CO2. This is the end product of glucose that we are having, right? This is the end product of momos that you are eating. What is going to happen, it will be utilized if you are working, if you are utilizing your body, right? आप exercise कर रहे हो, आप घूम रहे हो, फिर रहे हो, खा रहे हो, right? What is going to happen, you will be having utilization of this glucose, extra glucose, right? Whatever extra glucose will be utilized because of this insulin, and now you will be having what, normoglycemia. Now you will be having what, normoglycemia. This is the normal physiology that we are having, राइट? अब इसमें क्या हो सकता है, राइट? एक्स्ट्रा ग्लूकोज विल बी स्टोर्ड इन द फॉर्म ऑफ एडिपोसाइट्स, है ना, ये ग्लाइकोजन एडिपोसाइट्स की फॉर्म में ये एक्स्ट्रा ग्लूकोज स्टोर हो जाएगा, राइट? दिस इज गोइंग टू बी द एक्स्ट्रा ग्लूकोज दैट वी आर हैविंग. So what is going to happen, this extra glucose will store in the form of adipocyte. Now what you need to remember, this normoglycemia हो जाएगा यहाँ पर, right? This is what we want naturally in our body, this is what we want naturally in our body. But sometimes we have what, we have got problem. What are the problems we are having, either we are having the key, either we are having the key, this is the key, this is the insulin, हमारे पास में इंसुलिन होता है बट ताला खराब हो गया, this lock is not opening. If this lock is not opening, what you will do, आपका ताला नहीं खुल रहा है, you will be putting some oil. What is the oil that you are going to put, this is going to be type 2 diabetes mellitus. So insulin is there, key is present, but lock isn't opening. Lock is not opening. If the key is there and lock is not opening, you are going to give the drug of choice. This is going to be what, bache? Metformin. Metformin is the drug of choice that would you like to use. These are the biguanides that we are having, that we are going to use. आपके पास में ताला है, आपके पास में चाबी है, पर ताला नहीं खुल रहा, क्या करोगे? तेल डालो यहाँ पर. You are going to apply the oil, right? This is going to be the lubricant that you are going to apply. Drug of choice will be metformin. दूसरा डायबिटीज कैसा होता है? दिस इज गोइंग टू बी टाइप 1 डायबिटीज मेलाइटस. टाइप 1 में क्या हो गया? 1 को आई बना दो, 1 को आई बना दो. हियर यू विल बी हैविंग बीटा सेल डिस्ट्रक्शंस बेटा, बीटा सेल डिस्ट्रक्शन. एंड अगर बीटा सेल ही नहीं है, डू यू थिंक देयर विल बी की विल बी प्रेजेंट और एब्सेंट? रिमेंबर बेटा, की विल बी एब्सेंट हियर. चाबी ही नहीं है, इंसुलिन ही नहीं है, इंसुलिन ही नहीं है, तो क्या होगा? अगर चाबी ही नहीं है, हाउ यू आर गोइंग टू ओपन दिस? यू आर नॉट गोइंग टू ओपन दिस, राइट? सो यू विल बी गिविंग द ड्रग ऑफ चॉइस. द ड्रग ऑफ चॉइस इज गोइंग टू बी व्हाट बच्चे हियर? Insulin. Drug of choice in this particular case is going to be insulin, not metformin. Here we are going to use insulin here, right? एक मैंने बैक्टीरिया पढ़ाया था बैक्टीरियोलॉजी में, that is going to sorry, एक वायरस पढ़ाया था कल, right? In the last class we have discussed about a virus and that is known as Coxsackie B वायरस. रिमेंबर, Coxsackie B का इन्फेक्शन होगा, बॉडी के अंदर एंटीबॉडीज बनेंगी एंड दीज एंटीबॉडीज आर गोइंग टू किल बीटा सेल्स. दीज आर एंटीबॉडीज विच आर गोइंग टू किल बीटा सेल्स. ये मिस रिकॉग्नाइज करके बीटा सेल्स को मार देगा और उसकी वजह से क्या हो जाएगा? डायबिटीज मेलाइटस हो जाएगा पेशेंट को, राइट? सो Coxsackie B याद रखना है ना? ट्रीटमेंट क्या होगा? ट्रीटमेंट, you need to give insulin from outside, right? So have you written any drugs? Let me see. No drugs. If you have not written any drugs, so first drug that we are going to give is insulin. Why you have not written, right? Second drug we are going to discuss is going to be your metformin, also known as biguanides. This is going to be your metformin. Third drug that we are having, that is going to be what? These are your, look at the diagram. Once you look at the diagram, once you understand the story, it will be very very easy and simple. Nothing is there. आपने मोमो खाया, हाइपरग्लाइसीमिया हो गया, राइट? हाइपरग्लाइसीमिया की वजह से you will be having beta cells activation leading to release of insulin. This insulin will come here, this insulin will open the lock, extra glucose will go inside. This is the basic funda. अभी क्या हो गया? टाइप 1 डायबिटीज, इंसुलिन ही नहीं है, चाबी नहीं है इस ताले की, चाबी दे दो बाहर से. टाइप 2 डायबिटीज, चल चाबी तो है, ताला खराब हो गया. अगर ताला खराब हो गया तो ऑयल डालो इसमें. दिस इज गोइंग टू बी मेटफॉर्मिन. थर्ड ड्रग, नाउ ऑल द ड्रग्स, ओरल हाइपोग्लाइसेमिक एजेंट्स दैट यू आर गोइंग टू यूज आर गोइंग टू कॉज व्हाट? दे आर गोइंग टू कॉज द सेम थिंग. ये कुछ अलग नहीं करेंगे, अल्टीमेट फंक्शन इज व्हाट? बॉडी के अंदर ग्लूकोज नहीं रहना चाहिए, राइट? सो हाउ दे आर गोइंग टू स्टॉप द अवॉइडिंग ऑफ दिस ग्लूकोज? They are going to block this channel directly. Whatever drugs which are going to work on this ATP sensitive potassium channel, they are the drugs which are going to be working on ATP sensitive potassium channel. These are known as sulfonylureas. इधर लिख लेता हूँ. So we have got what? Sulfonylureas. These are going to be blocking the ATP. They are going to be blocking the ATP sensitive potassium channel. अगर ये ATP sensitive potassium channel को बंद कर देंगे तो क्या होगा? Depolarization हो जाएगा. Because of depolarization, what will happen? Calcium will come inside, insulin will release will be more. So this is the basic funda that we are having. They are going to increase the insulin. What are the example? These are going to be G plus side group of drugs. Major याद रख लो. These are going to be G plus side group of drugs. These are going to be gliclazide, gliblanclamide, okay, gliburide, gliclazide. All these drugs that you are telling me, they are going to be what? G plus side, okay. Gliblanclamide, glimepiride, all these drugs are going to be what? These are the sulfonylureas that we are having. Then we can do what? Then we can increase the incretin. What is incretin? Look at the diagram. What is incretin? This is the GLP-1 agonist receptor. This is the GLP receptor. These are the receptor. उनका function क्या होता है? Release of insulin को regulate करना. They are going to regulate the function. They are going to regulate the release of insulin. कितना insulin बाहर जाना है is going to be regulated by this incretin. right? These are the incretins we are having. So we have got incretin. तुम simple याद रखो, incretin is going to do what? Increase in insulin. This drug is also doing what? Increase in insulin, right? This drug is also going to do increase in insulin. This is the incretin. What is the incretin we are having? This is going to be GLP-1. So we can give the drug GLP-1 agonist. What are the drugs we are having? GLP-1 agonist. These are going to be the drugs with the glutide. These are going to be the drugs with the glutide. Okay, glutide. Okay, liraglutide. We are having drugs like glutide. Glucose and tide means it is going to be a protein. So this is going to be glucose or peptide, right? You can remember like that, glucose and peptide. This is going to be glutide group of drugs, right? Then we have got what? ये GLP-1 को तोड़ता है एक चीज. This is known as DPP-4. So we can give a class of drugs. These are going to be your DPP-4 inhibitor. We can give DPP-4 inhibitors. These are going to be gliptins. These are going to be gliptins. These are the inhibitors. Okay, glucagon peptide inhibitors. These are going to be the gliptins that we are having. These are your sitagliptin, linagliptin, vildagliptin, sitagliptin or linagliptin, right? These are the gliptins we are having, right? This is the gliptin we are having, right? Then we have got what? Then we have got another group of drugs. Okay, yes, you are right. Another group of drugs that we are having. This is going to be the sixth group of drugs that we are having. We have got alpha glucosidase inhibitor. Alpha glucosidase inhibitor is going to convert complex carbohydrate into simple glucose. Simple glucose, right? This is the function of this alpha glucosidase enzyme. We can give the drugs. These are going to be the alpha glucosidase inhibitor. So they are going to stop the conversion of glucose into. They are going to stop the conversion of carbohydrate into glucose. This is going to be your alpha glucosidase inhibitors that we are having. So what are the examples we are having, bache? What are the examples we are having, beta? We are having a carbose. We are having a carbose. We are having voglibose. A carbose. We are having voglibose. We are having miglitol. These are the drugs which are stopping the conversion, right? These are the drugs which are stopping the conversion. Then we have got what? Then we have got SGLT2 inhibitors. These are going to be your gliflozin. These are going to be your glucose flows in urine. These are the gliflozins that we are having. So we have got dapagliflozin, empagliflozin. Okay, these are the gliflozins. Then we have got what? Thiazolidones. These are going to be the drugs which are going to cause what? Like we are having pioglitazones. These are the glitazones we are having. Rosiglitazone, pioglitazone, troglitazone. This pioglitazone can cause bladder cancer, but they are having activity of PPR gamma activation. This is going to reverse the insulin resistance. Right, these are the major group of drugs that we are having. And lastly, we have got what? A myelin analog. This is going to be your pramlintide. Right, side effects you need to remember from pharmacology. These are the old drugs that we are having, right? This is going to be the short story about this this particular one. This is known as diabetes, right? We can also do HbA1c testing, which is nothing but your glycated hemoglobin or glycosylated hemoglobin. So normally when a hemoglobin is binded with the glucose, right? We don't want glucose in our blood. We don't want the ultimate purpose. We don't want this glucose in our blood vessel. If this glucose will be present in our blood vessel, it is going to macro vessels. It is going to cause macrovascular complication. If it goes to a small vessel, it is going to cause microvascular complication. We don't want this, right? So we are going to do what? HbA1c. This is going to be the glycated hemoglobin testing we can do, right? So we have got the answer. The answer for this particular one is going to be C. The answer for this particular one is going to be the C, right? The next one, we have got a 30-year-old female patient presented to OPD with the symptoms of excessive weight gain cold intolerance and menstrual disturbances, right? The diagnosis was made as Hashimoto thyroiditis. Since it is an autoimmune condition, the antibodies are formed against what? Yes, what they are talking about, 30-year-old female patient OPD में आ रही है with the symptoms of excessive weight gain, cold intolerance, menstrual disturbances, right? So these are the symptoms like weight gain, cold intolerance. Cold intolerance is a very characteristic symptom. Menstrual disturbances will be there, right? They can also have hair loss. The diagnosis was made as Hashimoto thyroiditis. This Hashimoto thyroiditis is the most common type of thyroiditis, most common type of hypothyroidism that we are having, right? The autoimmune condition, the antibodies are formed against what? What are the names of the antibody? This is the name of the antibodies. They are formed against transthyretin deiodinase enzyme, thyroid peroxidase, or thyroglobulin. The answer in this case is going to be thyroid peroxidase. Let's try to understand how this thyroid is going to function, right? So we have got this thyroid gland. This thyroid gland will be having what? These cells. What are these cells? We have got follicular cells. We have got nearby the follicle some cells. These are known as parafollicular cells. So we have got follicular cells, we have got parafollicular cells. ये जो follicle के आसपास वाले cells है, they are known as parafollicular cells, right? So what is the function of follicular cells? They are going to make T3 and T4. What is the function of parafollicular? They are going to make calcitonin, right? From where this thyroid is going to come, it is going to come get the message from the hypothyroid. Hypothyroid is going to release what? Thyroid releasing hormone. This thyroid releasing hormone will go to your anterior pituitary, and this anterior pituitary will release TSH. Okay, this anterior pituitary will release TSH. This TSH will come to the thyroid gland, and now this thyroid gland will produce what? T3 and T4. It is going to make what? T3 and T4. This is the basic cycle we are having. This is the follicle that we are having. These are the basic follicular cells that we are having. These are the basic follicular cells, and nearby these follicular cells are small parafollicular cells, and this is the cells which are having the blood vessel. So I'm just taking one part out. This is the one part that I'm taking out, where we are going to have what? The inner part. This part is known as what? Colloid, right? So what is going to happen? Let's try to understand. This is the thing we are having. This is the iodine that we are eating in the food. The iodine that we are eating in the food, this iodine will be coming to the blood. Blood is a connective tissue. It will be bringing this iodine to this particular pump. This is the iodine which is going to this particular pump, sodium iodide symport, right? What is the function of this sodium iodide symport? It will take this iodide ion directly into the follicle. This is a thyroid follicular cell. Now this iodide ion will go into what? This iodide ion is not utilizable here. This iodide ion will go into the colloid. This is the colloid that we are having, and this iodide ion will come into the colloid, and now the first reaction is going to take place. This reaction is known as what? Oxidation. Reduction of this electron will be there, loss of electron will be there, right? And this is going to be what? Oxidation reaction that we are going to have, and this oxidation is also going to happen in the presence of thyroid peroxidase. पहला क्या होगा? पहला चेंज होगा ऑक्सीडेशन. फिर क्या होगा? ये आयोडीन जब बन जाएगा, दिस आयोडीन इज फॉर्म. नाउ दिस आयोडीन विल बाइंड विद द another molecules of thyroglobulin, right? This iodine is going to bind with the single molecule of thyroglobulin. This is going to become what? Monoiodothyroglobulin. When these two molecules of iodine are going to bind with the thyroglobulin, they are going to become what? Diiodothyroglobulin. This is going to be monoiodothyroglobulin. This is going to be diiodothyroglobulin. अब क्या होगा? अब कपल बनेंगे, ऑर्गेनिफिकेशन हो गया, राइट? नाउ यू विल बी हैविंग कपल फॉर्मेशन. सो मोनो प्लस डाई इज गोइंग टू बी व्हाट? मोनो प्लस डाई इज गोइंग टू बी triiodothyroglobulin, and di plus di is going to become what? Tetraiodothyroglobulin. So this is going to be the T3, this is going to be the T4 formation from the food itself, right? खाने से बना दिया हमने T3 T4, and now this T3 T4 will come back to the follicle. This is the follicular cell. Now this T3 T4 will come back, and it will store in this particular follicular cells. Whenever a stimulus will come, beta, जब भी कोई स्टिमुलस आएगा, whenever stimulus will come, like TSH will come, thyroid stimulating hormone, this thyroid will stimulate this gland, and what is going to happen, this T3 and T4 will be coming back to the blood. Why to the blood? Because they are also what? They are also thyroid hormones. They are also the hormones will directly come into the blood vessel, right? So you will be having the activation of this T3 and T4 into the blood vessel, and this T3 and T4 are going to exert the actions, right? Whatever actions we are having, it is responsible for metabolism. What is the function of this T3 T4? Metabolism. So it is going to exert the functions of metabolism, right? We can have hypothyroidism, we can also have hyperthyroidism. Hypo में everything will be slow, right? Decrease in the metabolism will be there. In hyperthyroidism, there will be increase in the metabolism, right? This T3 T4 can go to the beta cells also, beta cells of the like beta receptors we are having. So it is going to go to the beta receptors, not beta cells. It is going to go to the beta receptors, right? And you already know the function of beta receptor, SA node, AB node, and muscle. They have the beta receptor. It will increase the heart rate, it will increase the conduction, it will increase the contraction. Okay, everything will be increased. You will be having what? It will also cause what? Increase in heart rate, increase in conduction, increase in contraction, and increase in renin, leading to increase in vasoconstriction. Renin will lead to increase in vasoconstriction, leading to increase in BP. So this patient will be having what? High BP. This patient will be having high conduction, contraction, high BP, everything will be more. This is also considered as the thyroid storm, and this is something that you will be finding in the hyperthyroid patient. They are having what? High heart rate, they will be having high conduction, they will be having palpitation, anxiety, high BP will be there. All these symptoms will be there. They are heat intolerant because already there is vasoconstriction that is happening. These are the people who are heat intolerant. Why heat intolerant? They cannot sit in the heat environment because they are already having the vasoconstriction. High blood flow is there, right? What happens? How your body will generate the heat? By causing the vasoconstriction. How your body will lose the heat? By causing vasodilatation, right? So vasodilatation is going to happen in the hypothyroidism, leading to decrease in the metabolism also, right? You can explain this also, right? What is the treatment for this particular one? The treatment, what is the thing we are having? Just try to understand this. In hypothyroidism, you are having antibody against this TPO. This antibody against this TPO, anti-TPO antibodies are there, and remember, this anti-TPO antibodies are going to cause what? Do you think you can make T3 and T4 if you do not have all these reactions? Remember, they have asked question on the basis of the reaction. The first reaction is oxidation, second is organification, last is going to be the couple formation sequence they have asked, right? And all these three reactions are catalyzed by the same enzyme. This is going to be thyroid peroxidase, right? So if there is antibody against this thyroid peroxidase, you will not have what? You will not have T3, you will not have T4. This is known as hypothyroidism. You can do what? You can supplement the patient, you can give thyroid from outside. This is going to be levothyroxine. What is the dose? The maximum dose, that is going to be 1 to 1.6 times of the body weight, and you need to look for the TSH of the patient. You need to make the TSH okay, right? This is how you will be treating this particular patient. This is the patient of hypothyroidism, है ना? आप TSH T3 T4 का वैल्यू चेक करोगे, TSH को नॉर्मल लेके आओगे. This is how you will be treating this patient. If this TSH is going to be more, what is going to happen? This patient will be having what? This patient will be having goiter. TSH is more, that means what is going to happen? This TSH is going to send a message to the thyroid gland. TSH जाके message भेजेगा. And what is the property of a muscle? Property of a cell, either it can grow in number, either it can grow in size. What is going to happen? You will be having message coming, right? What is going to happen? There will be increase in the size of the thyroid. Without TPO, it cannot make what? It cannot make T3, T4, but it can increase in the size only, right? So it is going to increase in the size only, right? You understand this? What happens in hyperthyroidism? You can also understand the treatment for hyperthyroidism. You can give drugs which are NIS inhibitor. You can block this one. No iodine will go inside. You can block this one. These are going to be perchlorate and thiocyanate. These thiocyanates will be present in cabbage also. You can give TPO inhibitor drugs. These are going to be what? Carbimazole, methimazole, propylthiouracil. These are going to be the drug of choice. You can give secretion inhibitor, that is your sodium iodide or potassium iodide compounds, right? You can also do peripheral conversion inhibitors. These are going to be the drugs. And you can also give gland destroyers, which are going to be iodine 131, which is going to emit beta rays. These beta rays are going to damage the thyroid gland. And symptomatic treatment for thyroid storm is going to be what? Beta blocker. This is propranolol. Why? Because all these receptors, all these symptoms are happening because of this beta receptor, so you can block that also, right? So short summary about this particular one. The next one we have got is going to be your 15, that is going to be a 76-year-old male patient is presented to emergency department with the symptoms of stroke. This patient is having symptoms of stroke. On examination, doctor performs the test that comes out to be positive. All of the following can be true about this particular condition except. यहाँ पर सब all of the following can be true about this particular condition except. What do you think? What is going to be your answer here? What is this test is known as? This test is known as, you are going to take out the key or something and you are going to start from this particular border and you are going to go like that. This test is known as what? This test is known as what? This test is known as Babinski reflex beta. The test they are talking about is about the Babinski test. Very good, Molstri. This is the Babinski test that we are discussing about, right? So what is going to be the features of this Babinski reflex is going to be positive in which test? Read the question carefully. Babinski can be positive, right? Doctor performs the test that is coming out to be positive. That means this is a Babinski positive. Babinski positive means which palsy will be there? Upper motor neuron is gone or lower motor neuron is gone. And then I will make you understand how you will, how this information is going to your brain. It is very, very simple. How this information is going to your brain, how the information is coming from the brain, how you are going to make the actions. This is going to be very, very simple, right? This is going to be very, very simple that we are having, right? So what is the type of palsy that you are expecting here? Is it upper motor neuron? Is it lower motor neuron? Is it receptor problem? What is, where is the lesion? Right, upper motor neuron, let me give you a very simple example that we are having. What is this upper motor neuron? What is this lower motor neuron? And what is this particular palsies that we are having? This is going to be the basics that we are having. All of you agree with that? This is upper motor neuron. Yes, whenever you have got upper motor neuron, we have got three things: upper motor neuron, lower motor neuron, and receptors. Okay, just think like that. Let me give you a simple example. How this thing is going to happen? What are the different pathways we are having? How the information is going into the brain? This is the different pathways we are having. The information will go into your brain with the help of certain pathways. This is going to be your spinothalamic tract. First tract that we are having is going to be a spinothalamic tract. Second tract that we are having is corticospinal tract. From the information from the cortex, corticospinal tract, the information from the cortex is going to come to the lower part of the body. This is known as corticospinal tract. दो तरीके की tract होंगी. One is known as spinothalamic. That means how this information is traveling from the spine to my head, right? How I am going to perceive the pain, how I am going to understand all those things is going to be what? A spinothalamic tract. Spinothalamic tract, right? From the spine to the thalamus. We have got certain fibers, right? We have got certain fibers. What are the different fibers we are having? This is just like the current, right? I'm just cutting my spinal cord and presenting in front of you. So what is there in the spinal cord? Let's try to understand what are the pathways we are having. the information can go into your brain via three pathways. This is the cross section of the spinal cord, beta. So information in your brain can go through three pathways. What are those three pathways? It can go through anterior pathway, it can go through lateral pathway, it can go through dorsal pathway. These are the three pathways we are having. Anterior spinothalamic tract, because the information is going up. I can name it spinothalamic, yes or no? From the spine to the thalamus in the brain, this is your anterior spinothalamic tract. We have lateral spinothalamic tract, we have dorsal spinothalamic tract, right? This is going to be the uptake of the information from the spine to the head, right? But the information can come below via two pathways only in the spinal cord. This is going to be your lateral spinothalamic, this is going to be lateral corticospinal. Now corticospinal, from the cortex to the spinal, right? So we have got lateral corticospinal tract, we have also got anterior corticospinal tract. So we have got two types of we have got two types of corticospinal, we have got three types of spinothalamic tract. बात समझ में आ रही है, right? So spinothalamic means it is going to take the information from the spine to thalamus, body to thalamus, right? And if the information is coming from head to body or brain to body, this is known as corticospinal, cortex से spine की तरफ, right? So now let's try to understand how this pathways we are having. So let's begin with the anterior ascending pathways first. Ascending pathway में क्या याद रखना है? We have got spinothalamic pathway. Spinothalamic means the information from the spine to the thalamus. तो कैसे जाएगा बेटा? लात पड़ेगी तो क्या होगा? दर्द होगा और टेम्परेचर बढ़ेगा, right? So you can simply remember lateral spinothalamic tract is responsible for the transport of pain and temperature. Pain and temperature is transferred through this lateral spinothalamic tract, whereas आंटी, you can remember आंटी का टच कैसा होगा? This is going to be light touch, crude touch, or pressure will be there. This is going to be the light touch, crude touch, or pressure will be there, and sexual sensations will be there, right? This is going to be what? This is going to be which pathway? This is going to be anterior spinothalamic pathway. So we have got lateral spinothalamic pathway, we have got anterior spinothalamic pathway, right? So anterior से क्या जाएगा? Anterior से क्या जाएगा? This is going to be your आंटी से याद रखना है, आंटी से याद रखोगे, crude touch, pressure, crude touch will be there, pressure will be there, and sexual sensation will be going through which pathway? आंटी वाला pathway. लात पड़ेगी तो pain and temperature will be going through which pathway? This is your lateral wala pathway. And dorsal is responsible for two important things. Let's try to understand what is this dorsal will be having. Dorsal will be having two nucleus. One is going to be gracilis, second one is going to be cuneatus. Gracilis is going to take information. Gracilis is going to take information from the legs. It is going to take information from the legs. Race कैसे करोगे? From the legs, right? And cuneatus is going to take, it is going to take information from the hands, बेटा. यहाँ पर इंफॉर्मेशन कहाँ से जाएगा? एक में हाथों से जाएगा, एक में पैरों से जाएगा. कौन सा इंफॉर्मेशन? फाइन टच, प्रोप्रियोसेप्शन, 2 पॉइंट डिस्क्रिमिनेशन. बेटा कोई भी फाइन टच है, प्रोप्रियोसेप्शन है, 2 पॉइंट डिस्क्रिमिनेशन है, दे आर गोइंग टू बी टेकन अप बाय डोर्सल कॉलम पाथवे. कौन से पाथवे से जाएंगे ये सब? डोर्सल कॉलम पाथवे से. इंफॉर्मेशन इज गोइंग टू गो अप इन वाया dorsal column pathway. This is going to be fasciculus gracilis, this is going to be fasciculus cuneatus, fasciculus gracilis or cuneatus, okay? Or you can remember anything, right? Race, right? Now what is going to happen? Let's try to understand. Let's try to understand this particular pathways that we are having. Now we have got some type of things. Let's try to understand this particular pathway first, then you will be able to understand the lesions, right? So what are the pathways I'm taking? I'm just talking about the pain, okay? I'll teach you, we will get some fibers, like we have got A alpha fiber, A beta, A gamma, A delta fiber, right? So remember beta, A delta fiber is the fiber for pain. It is the fiber for fast pain. It is the fiber for fast pain. And C fibers are the fibers for slow pain. है ना, आगे बताऊंगा, इसी में बताऊंगा. Today I will teach you, right? So just remember for now, A delta is responsible for fast pain, C fiber is responsible for slow pain. Fast pain क्या होता है? For example, I'm giving you some, I'm pinching something on you, right? मैं तुमको नीडल चुबा रहा हूँ, राइट, लेट्स से आई एम जस्ट ट्राइंग टू इंजेक्ट समथिंग इनटू यू and the first time you will be having the pain, pehla dard, first pain, this is also known as epicritic pain. This is the first pain, fast pain, or fast pain you can call it. This is due to A delta fibers, and A delta fibers are the fast fibers, whereas C fibers are the slow fibers. Like you go for TT injection, tetanus wala injection, so what is going to happen, tetanus wala injection में first fiber will be A delta fiber. तो पहली बार जब इंजेक्शन लगाएगा दर्द होगा, दैट इज गोइंग टू बी ए डेल्टा फाइबर, एंड देन उसके बाद में यू विल बी हैविंग कंटिन्यूअस स्लो पेन, दिस इज गोइंग टू बी व्हाट, नेक्स्ट डे यू विल बी हैविंग पेन, दिस इज ड्यू टू सी फाइबर्स, है ना, दिस इज ड्यू टू सी फाइबर्स. सो व्हाट इज गोइंग टू हैपन, जस्ट ट्राई टू अंडरस्टैंड. सो when I'm injecting something, for example मैं deltoid पे किसी के क्या लगा रहा हूँ, टिटनेस लगा रहा हूँ, what is going to happen, और कोई मेरे लगा रहा है, what is going to happen, I am going to have activation of some fibers. What fibers will be activated? First time when someone is injecting something, I am going to have activation of A delta fibers. Very very important, you will get to know how our body is functioning, right? So this is going to be what, this A delta fiber is going to take the information where, this information will be going to my spinal cord. यहाँ injection लगाया, this information will go to my spinal cord, and in my spinal cord which pathway will be activated? Now you will be telling me what is happening with me, टच हो रहा है, टेम्परेचर हो रहा है, प्रोप्रियोसेप्शन है, 2 point डिस्क्रिमिनेशन है, या फिर पेन है? सर इट इज पेन, इट इज पेन. सो व्हाट विल हैपन अबाउट द पेन, दिस पेन इज गोइंग टू टेकन अप बाय विच पाथवे, लात पड़ेगी तो दर्द होगा, so this is going to be what, this is going to be lateral pathway which is going to take up this information where, this is a spinothalamic tract, यहाँ से क्रॉसिंग होगा, ये एनाटॉमी में पढ़ा होगा, राइट, crossing will be happening and this information will be taken up from my spine to the thalamus. This is known as spinothalamic tract, right? और thalamus में जाने के बाद में क्या होगा, this information, my thalamus will get to know this is A delta fibers which are bringing the pain. That means they are fast pain or slow pain. बॉडी को कैसे पता चलेगा ज्यादा तेज दर्द है कि स्लो दर्द है? बॉडी विल असेस द फाइबर्स. इफ दे आर ए डेल्टा फाइबर्स, दिस इज गोइंग टू बी व्हाट, this is going to be fast pain, right? This is going to be fast pain. So what is going to happen, the sensation will be going to the relay station in the thalamus, and thalamus will get to know where we need to send this information. अब जो तुम्हारा thalamus है वो तुम्हारी information को भेजेगा somatosensory cortex में, and this somatosensory cortex will be having division. For example, तुम मेरी उंगली में पिन चुबा रहे हो, राइट, यू आर जस्ट ट्राइंग टू गेट माई सैंपल फॉर द ब्लड शुगर, है ना, आपने यहाँ पिंच किया. सो हाउ दिस इंफॉर्मेशन इज गोइंग टू ट्रेवल, जस्ट ट्राई टू अंडरस्टैंड दिस इंफॉर्मेशन विल ट्रेवल वाया विच पाथवे, ए डेल्टा और सी फाइबर. Very good, A delta fiber, because it is a fast pain. This fast pain will be traveling all the way back to my spinal cord. From the spinal cord, which pathway will be activated? Lateral spinothalamic tract will be activated, and lateral pathway will take up the information to my thalamus, and from the thalamus this information will go to my somatosensory cortex, right? And which finger you are putting, which finger you are touching, it will be depending on the finger. You will be having these fingers, है ना. sensory homunculus आपने पढ़ा होगा. sensory homunculus will be getting, every part is getting some representation in your brain, है ना. area number 312 we have got like somatosensory cortex. So we will be having, every part has got some representation, right? For example, this is your finger, and in finger itself there is a representation for the middle finger. So our brain will get to know कि किसी ने middle finger में कुछ ना कुछ चुबाया है, right? Someone is trying to draw the sample out of us, right? So what is going to happen now? What will happen now? This motor cortex is coming into action, right? This motor cortex is going to come into action, and your fingers will try to move, right? How they are going to move, let me make you understand. From the brain the information will go. Now these are the fibers which are going to take the information from the brain. So they are cortico-spinal tract. So from the brain this information is going to come, it will cross here, and 90% will come in the lateral pathway, and approximately 10% will come in the anterior pathway. This is what we have understood. And now this information will go to my hand, and this is going to be A alpha fiber, which are the fastest fiber. मैं फटाक से हाथ हटा लूँगा, right? This is the A alpha fiber. This is very heavily myelinated. I am going to remove my hand as soon as possible. मुझे समझ में आ जाएगा मेरे को दर्द हुआ. आप इस कनेक्शन को कहीं से भी काट दो, माई बॉडी विल नॉट गेट टू नो कि मुझे दर्द हो रहा है. आप क्रॉस में ए डेल्टा फाइबर्स को कट कर दो बीच में से, दिस इज नॉन एज एनेस्थीसिया, राइट? दिस इज व्हाट इज यू आर डूइंग इन द एनेस्थीसिया, राइट? सो यू अंडरस्टूड. सो इंफॉर्मेशन फ्रॉम द ब्रेन इज कमिंग, right? Via which pathway? Corticospinal tract. Information from the brain is coming via corticospinal tract, and this information will come to where? This information will come till this anterior horn cell. This is known as what? This yellow part is known as upper motor neuron, and after this, from the head to the spinal cord is going to be upper motor neuron, and then after this, what is going to come out is known as lower motor neuron. From the spinal cord to the periphery is known as lower motor neuron. So this is what is upper motor neuron, this is what is lower motor neuron, and this is how we can feel and sense the things. This is how we are assessing the things, everything, right? You got this? Right? Now what is going to happen if you have upper motor neuron lesion? Upper motor neuron lesion मतलब यहाँ ब्रेन से लेकर स्पाइनल कोड तक अगर कोई भी दिक्कत है, दिस इज कंसिडर्ड एज अपर मोटर न्यूरॉन. स्पाइनल कोड से लेकर पेरिफेरी तक कोई भी इश्यू है, दिस इज कंसिडर्ड एज लोअर मोटर न्यूरॉन, है ना. आई एम गिविंग यू सिंपल निमोनिक सिंपल आइडिया that is going to help you out, right? So what is this upper motor neuron lesion and lower motor neuron lesion? अगर आपका अपर मोटर न्यूरॉन लीजन हो गया, जस्ट ट्राई टू अंडरस्टैंड, दिस इज लाइक अ कोचिंग, or this is like a company, or this is like a boss, right? And these are the workers, these are the let's say teachers, and you are the students, right? You are the students. So what is going to happen if the lesion is in the coaching? The lesion is in the coaching. कोचिंग नहीं है तो क्या टीचर बच्चों को पढ़ा सकता है? क्या एक्टिविटी होगी? Yes, element can activate your receptors, your teacher can teach the student, right? So this is going to be the first thing we are having, and this is going to be the first thing we are having. If there is upper motor neuron lesion, upper motor neuron lesion हुआ, so what is going to happen? अगर ये कोचिंग नहीं रहा, अगर कोचिंग नहीं रहा तो क्या टीचर बच्चों को पढ़ाएगा? यस पढ़ाएगा. क्या एक्टिविटी बढ़ेगी? यस एक्टिविटी बढ़ेगी. सो यू जस्ट रिमेंबर अपर मोटर न्यूरॉन लीजन, एवरीथिंग विल इंक्रीज, everything will increase, everything will increase, activity will increase, right? You will be having tone in the muscle, yes, tone will be positive. You will be having Babinski positive, yes, Babinski will be positive. You will be having what kind of paralysis? A spastic paralysis. A spastic paralysis मतलब खतरनाक वाला paralysis will be there. You will be having some spasm. What about deep tendon reflex? आप reflex check करोगे मार के, you will be having DTR positive. Everything will be positive here. But what about this element palsy? When you have lower motor neuron palsy, that means problem is where? After the spinal cord, problem is in the body. This is going to be lower motor neuron palsy. LMN अगर गया, टीचर अगर गया तो क्या कोचिंग आपको पढ़ाएगी? अगर टीचर नहीं है, if teacher is not there, do you think there will be activity? Without teacher, without faculty, how you are going to understand, how you are going to read? You cannot study, right? This is going to be what? LMN palsy. अगर LMN गया तो you will be having decrease in everything, decrease in tone, decrease in muscle power, decrease in tone. And what kind of paralysis will be there? This paralysis is known as flaccid paralysis. Very very important. फ्लैसिड पैरालिसिस. बेबिंस्की यहाँ पर नेगेटिव आएगा बच्चों, बेबिंस्की यहाँ पर नेगेटिव आएगा. डीप टेंडन रिफ्लेक्सेस यहाँ पर कम हो जाएंगे. एवरीथिंग विल बी लो, एवरीथिंग विल बी लो. नाउ यू टेल मी, ओके, स्ट्रोक अगर किसी पेशेंट को हुआ है, अब हाउ यू आर गोइंग टू असेस दिस इंफॉर्मेशन? दिस इज इंफॉर्मेशन यू विल यूटिलाइज इन योर हॉस्पिटल इमरजेंसी में. कोई भी पेशेंट आए, यू जस्ट डू दिस बेबिंस्की टेस्ट. अगर बेबिंस्की पॉजिटिव आ रहा है मतलब क्या है? आप उसका मसल का टोन चेक कर लो पेशेंट का. अगर मसल का टोन ज़्यादा है तो कैसा पैरालिसिस है? स्पास्टिक पैरालिसिस है. तो क्या पता चल जाएगा? अगर स्पास्टिक पैरालिसिस है, मसल टोन ज़्यादा है, सारी चीज़ें पॉजिटिव है, अपर मोटर न्यूरॉन लीजन है, यानी लीजन का है या तो ब्रेन में है या फिर स्पाइनल कॉर्ड में. दिस इज अपर मोटर न्यूरॉन लीजन. यू नीड टू डू फॉर CT स्कैन कराना है, इसका आइडेंटिफाई करना है स्ट्रोक कौन सा है, राइट? अगर लोअर मोटर न्यूरॉन लीजन, इट कैन बी अदर डिजीजेज ऑल्सो, लाइक वी डिस्कस्ड इन द माइक्रो में हमने पढ़ा था, स्वान सेल के अगेंस्ट एंटीबॉडी बन गया, दैट इज गोइंग टू बी व्हाट? गुलियन-बारे सिंड्रोम. इट इज अ लोअर मोटर न्यूरॉन लीजन, है ना? असेंडिंग मसल, असेंडिंग पैरालिसिस विल बी देयर. सो दिस इज हाउ वी कैन अंडरस्टैंड, राइट? इन दिस पर्टिकुलर केस व्हाट इज गोइंग टू बी योर आंसर? hypertonicity will be there. It is a stroke अगर patient को है तो what is going to be the type of paralysis will be not be there. All of the following can be features except पूछा है तो क्या हो जाएगा? Flaccid paralysis will be the answer. You got this? Flaccid paralysis will be the answer. दोनों बातें समझ में आ गई? All right. Yes, D will be the answer in this particular case. विच ऑफ द फॉलोइंग इज द डोमिनेंट मोटिलिटी इन द जीआईटी? जीआईटी के अंदर डोमिनेंट मोटिलिटी कौन सा है? डोमिनेंट मोटिलिटी क्या होगा जीआईटी के अंदर? सो रिमेंबर व्हाट इज द डोमिनेंट मोटिलिटी इन जीआईटी? इन फेड स्टेट, जब आप खाना खा लोगे, व्हेन यू आर इन अ फेड स्टेट, व्हाट इज द डोमिनेंट मोटिलिटी इन जीआईटी? व्हाट इज गोइंग टू बी द डोमिनेंट मोटिलिटी इन जीआईटी इन फेड स्टेट? It is going to be LMN beta. Anterior horn cell के बाद में is going to be LMN, LMN palsy. तो इसका आंसर करो, what is going to be the answer in this particular case? Which of the following is the dominant motility in GIT? It's okay. Try to answer this one. Just give me a moment. Not see the screen. Let's take a break for five minutes. I'll just fix it. All right. So which of the following is the dominant motility in GIT? Let's try to understand the dominant motility in GIT. Which of the following is the dominant motility in GIT in the fed state? When you are eating the food after that, which is going to be the dominant motility? What is going to be your answer in this case? Try to answer this one. So dominant motility in GIT, what is MMC? What is MMC? Migratory motor complex. This is a migratory motor complex. This is a strong wave of contraction, beta. Strong wave of contraction arising from mid part of the stomach, and it will go till terminal ileum. It will go till terminal ileum. This is the strong wave of contraction that is arising from the mid part of the stomach to terminal ileum, right? In the fed state, the dominant motility is going to be segmentation, beta. Segmentation is going to be the right answer. Peristalsis is not in the fed state. Fed state में अगर peristalsis होगा तो सारा खाना क्या होगा, बाहर चला जाएगा, right? What is this mass movement? This mass movement is urge to defecate. Urge to defecate, it comes 2 times a day. Normally in adult individuals, 2 times a day, right? In children, you can have this because of gastrocolic reflex. Okay, in children, it can happen because of gastrocolic reflex, beta. So what happens in gastrocolic reflex? As soon as this mother is feeding the baby, okay, mother is feeding the baby, what is going to happen? The baby will be having what? Baby will be having defecation. This is a gastrocolic reflex that we are having, right? What about this segmentation? What is peristalsis? Let me make you understand. This peristalsis is due to 2 important things, right? This peristalsis, posterior segment will be contracted and the anterior segment will be relaxed. This is known as what? Peristalsis. Posterior segment will be contracted, right? Posterior segment contraction is known as what? Peristalsis. And anterior segment will be doing what? Anterior segment will be relaxation. So posterior segment contraction is due to what? Contraction in the GIT is due to acetylcholine or substance P. Substance P or acetylcholine. Whereas this relaxation is due to what? Nitric oxide and vasointestinal peptides. This nitric oxide and vasointestinal peptide is responsible for what? It is responsible for the relaxation here. This is going to be the relaxation thing, right? So posterior segment is contracted, anterior is dilated, posterior contracted, anterior dilated. Like this food is going to move. This bolus is going to move in the body, right? Now, what is the segmentation, beta? What is the segmentation? The segmentation is going to take place where this one segment is going to get constricted, the same segment is going to get dilated. यही वो segment है जो contract होगा, यही वो segment है जो dilate होगा. You will be having constriction, dilatation, leading to what? Leading to breakdown of the complete food. And this is what is known as what, beta? This is known as segmentation. इसी को हम क्या बोलते हैं? इसी को हम लोग बोलते हैं segmentation. So this is going to be the segmentation is going to be the answer in this particular case. The next one that we have got, which of the following fibers is responsible for transmission of slow pain? Now I hope you will be able to answer this one. Which is responsible for the transmission of the slow pain? Slow pain is due to what? A alpha, A delta, B fibers or C fibers? Which is the fiber which is going to transmit the slow pain, beta? Slow pain के लिए कौन से fibers होते हैं? C fibers. Very good. This is going to be the C fibers. A delta is for the fast pain. Fast pain, also known as epicritic pain. Whereas the C fibers are responsible for the slow pain. B fibers are responsible for touch and pressure. Like I can give you one example, like those people who are having pain, है ना? जब दर्द होता है तो आप लोग क्या कराते हो, मसाज कराते हो, यू डू मसाजिंग, यू गो फॉर मसाज, राइट? So what is that massage is going to do? It is going to activate your B fibers, and when you have activation of B fibers, what will happen? The A delta and C fibers are going to stop the transmission for some time, right? That is why you are going to have relief in the fast and slow pain when you are activating your B fibers, है ना? इसे मसाज का क्या सेंस है, यही सेंस है, राइट? दिस इज गोइंग टू बी जस्ट फॉर अ टेम्पररी टाइम भी. So let's try to understand what is this particular classification we have got. This classification is known as Erlanger and Gasser classification of the nerve fibers. And on the basis of that classification, we have got what? We have got A alpha, A beta, A gamma, A delta, B or C fibers. These are just like the chargers that we are having. है ना, कुछ chargers are going to be fast chargers, some chargers are going to be slow chargers, right? So likewise we are having neurons in our body. Some neurons are faster neurons, some neurons are slower neurons, and all this charging thing or all this fast thing, slow thing is based on one important thing, that is myelination. More the myelinated the fiber, the better the speed will be, right? So you can appreciate the more myelinated will be what? This particular A alpha is the most myelinated fiber. It is the fastest fiber that we are having. So the conduction velocity is what? Conduction velocity is also fastest, and speed is also fastest because the size is also biggest, right? So जितना मोटा फाइबर होगा उतना फास्ट होगा. मैं आपके ऊपर पत्थर मारूंगा, कौन सा फाइबर एक्टिवेट होगा मोटर फंक्शन के लिए? दिस इज गोइंग टू बी व्हाट? ए अल्फा फाइबर, राइट? आपको धीरे धीरे, मैंने इंजेक्शन लगाया, आपको कौन सा फाइबर एक्टिवेट होगा? फर्स्ट पेन, इंजेक्शन लगाते ही कौन सा फाइबर एक्टिवेट होगा, या पिंच करते ही कौन सा फाइबर एक्टिवेट होगा? ए डेल्टा फाइबर्स, दे आर गोइंग टू बी फास्टर. सी वाले ज्यादा फास्ट होंगे, ए डेल्टा ज्यादा फास्ट होगा. लुक एट द डायमीटर, लुक एट द कंडक्शन स्पीड ऑल्सो. सो सी फाइबर्स आर ऑल्सो रेस्पॉन्सिबल फॉर टेकिंग अप द स्लो पेन, धीरे वाला दर्द जो इंजेक्शन के बाद में आपको कंटिन्यूस होता रहेगा. फॉर एग्जांपल यू आर टेकिंग अ टीटी इंजेक्शन, सो नेक्स्ट डे यू आर हैविंग पेन, उसके बाद में 2-4 दिन तक जो आपको दर्द होता है, दैट इज गोइंग टू बी स्लो पेन, एंड दिस स्लो पेन इज ड्यू टू, this is due to C fibers. Fast pain is due to A delta fibers. So this A delta fibers are responsible for the fast pain, whereas the C fiber is responsible for the slow pain, right? Pressure and touch is responsible for the beta fiber. तभी अपन मसाज कराते हैं. What is going to happen because of massage? You will be having blockage of this A delta and B fibers. This is going to be the A beta fibers. They are going to be more faster. They stop the projection of A delta and C fibers, right? This is going to be your A beta fibers. You understand this, right? Next thing we have got this classification. The name of the classification is Erlanger and Gasser classification. Sir, what kind of question they will be asking? They will be asking you which is the fiber which is responsible for the fast pain. Your answer will be A delta fiber. Which is the fiber which is responsible for slow pain? Your answer will be C fiber. Which is the fiber which is having fastest conduction velocity? Fastest conduction velocity, I have given you the concept, more myelination, fastest conduction velocity, A alpha fibers. Which is the fiber which is the slowest fiber? Your answer will be slowest fiber is going to be your C fiber. Which is the fiber which is responsible for the touch? This is going to be A beta fiber. बात समझ में आ गई? For example, any pain, for example, pain is taken up by different route, okay, pressure is taken up by different route. A gamma is responsible for the muscle spindle. You can also remember this mnemonic. What is the mnemonic? The mnemonic is prime minister pressurized to sign the contract fast. So prime minister is proprioception, motor function. Pressurized to is what? Pressure and touch. Sign is spindle. The contract fast is going to be touch, cold and fast pain, right? Which is the fiber which is responsible for that cold temperature? This is going to be what? A delta fiber. Next question they have asked is about the pressure susceptibility. Which is fiber which is more susceptible to pressure? This is going to be A followed by B followed by C. Which is the fiber which is more susceptible to hypoxia? B followed by A followed by C. This is the sequence you need to remember. Okay, ये याद हो गया तो अपन ऊपर वाले क्वेश्चंस जो हम लोगों ने देखे थे, these questions you can easily understand, है ना? For example, कोई मुझे यहाँ पिंच करेगा, which fiber will be activated, which fiber will be taking the current? This current will be taken up by A delta fiber. कहाँ जाएगा स्पाइनल कॉर्ड में? लेटरल स्पाइनोथैलेमिक ट्रैक्ट में जाएगा और यहाँ से ब्रेन में जाएगा, और ब्रेन में जाने के बाद में पता चलेगा ब्रेन के अंदर सोमेटोसेंसरी कॉर्टेक्स में कि इस उंगली के अंदर किसी ने पिंच किया है. फिर इंफॉर्मेशन यहाँ से निकलेगी, मोटर कॉर्टेक्स से इंफॉर्मेशन विल स्टार्ट टू कम, and this information will come through upper motor neuron. This upper motor neuron will bring it till here, and from here this information will go to lower motor neuron, and which is the fiber which is responsible for motor functioning. Motor functioning के लिए ए अल्फा, फटाक से मैं अपना हाथ पीछे खींचूंगा, राइट. दिस इज गोइंग टू बी ए अल्फा फाइबर. वाई? बिकॉज मोटर फंक्शनिंग इज ड्यू टू ए अल्फा, इसलिए मैं अपना हाथ फटाक से वापस खींच लूंगा. दैट इज वाई इट इज द फास्टेस्ट वन. मोटर फंक्शनिंग, मैं आपके ऊपर पत्थर मारूं, आंख के अंदर कुछ मारूं या कुछ डालने की कोशिश करूं, व्हाट इज गोइंग टू हैपन? यू विल बी ब्लिंकिंग योर आईज और यू विल बी going away, right, as soon as possible. Why? Because they are the fastest one, है ना, ये सबसे fast है, right. You got this. This is the Erlanger and Gasser classification. Now the answer for this particular question is going to be slow fiber. You have already given, this is going to be C fiber, है ना. ये एक बार classification देख लेना, बस simple है, काम हो जाएगा अपना. Next question we have got is a 26-year-old male patient is sent for cholecystectomy. What is this cholecystectomy? Under general anesthesia. During the anesthesia, the patient start hyperventilating. During the anesthesia, and the value of EtCO2 is alarmingly high. On capnography. Yes, obviously we can see the values on capnography. Which of the following mutation can be responsible for this? Yes. Try to participate here. What is going to be the answer here in this particular case? Now let me make you understand how these organs are working, right? For example, the information will come from my head through my some neurons will bring this information. For example, I want to contract my this hand, right? So this information will come till this particular part, and here you will be having what? This neuron will be there. This is going to be the neuron, and you will be having this muscle junction. You will be having this junction. This junction is known as neuromuscular junction. This junction is known as neuromuscular junction. Always remember, the information will travel because of sodium and potassium, right? So sorry, sodium is going to be the main thing which is going to responsible for the conduction, right? This is the sodium which is traveling all the way up. The nerve conduction is due to sodium, and this sodium is responsible for the traveling, है ना. सोडियम ट्रेवल करके आ रहा है. what is going to happen? This sodium is going to cause what? Action potential. This sodium is going to cause what? Action potential. And when this sodium is going to cause what? Action potential, this sodium entry will lead to what? Calcium channel opening. And when there is opening of the calcium channel, what is going to happen, beta? This calcium is going to come inside. Once this calcium is going to come inside, what are the three functions I've told you about calcium? Three functions of calcium. Calcium is going to do in muscle, it is going to do muscle contraction. In vessel, it is going to do vasoconstriction. In cell, it is going to do what? Exocytosis, right? So this calcium is going to do all these three functions. This is going to be muscle contraction, it is going to do vessel contraction, it is going to do exocytosis will be there, right? So all these three things will be there. Muscle contraction, exocytosis will be there. So as soon as this calcium will come inside, what is going to happen? You will be having the vesicles of this acetylcholine, and now this vesicle will start to come here. Now this vesicles will start to come here, and when this acetylcholine will start to come here, what is going to happen? It is going to activate the sodium on the motor end plate. You will be having activation of these receptors, and these receptors, when they will get activated, they will be releasing sodium. Sodium is going to cause what? This sodium is going to cause generation of action potential, right? The sodium is going to cause what? Generation of action potential. Plus what is going to happen? You will be having ryanodine receptor, and this ryanodine receptor is going to bind with the dihydropyridine receptor, and they will be causing a mechanical change will be there. Remember beta, a mechanical change will be there, and this mechanical change is going to do what? It is going to activate your sarcoplasmic reticulum, and this sarcoplasmic reticulum will lead to increase in calcium, and this calcium now is going to do what? Now this is the calcium which is responsible for the muscle contraction. So now this calcium is going to do what? Muscle contraction. This is the basic thing we are having, right? If you block this sodium, what will happen? There will be no conduction of the nerve, right? No current will travel in the nerve, no information will travel in the nerve. This is what is known as anesthesia, right? If you have mutation in this calcium channel, this is going to be Lambert-Eaton syndrome. This is going to be Lambert-Eaton syndrome will be there. right? And if you have mutation, where is the mutation? If you have mutation in these receptors, you will be having problems with these receptors. That is going to be what? Myasthenia gravis. Myasthenia gravis, right? So these are the things you need to remember, right? So what is going to happen in this particular patient? This is a case of anesthesia, and in anesthesia, if someone is having mutation of this ryanodine receptor, after appliance of what? General anesthesia के लिए you can use two things. Tomorrow I think I will be teaching you anesthesia, right? So in anesthesia you will be learning about inhalational anesthetic agent and IV anesthetic agent. So if I'm talking about inhalational anesthetic agent, that is going to be halo, iso, CO and des, right? If you are having anything out of them, or IV agents, or you have things like succinylcholine, this muscle relaxant like succinylcholine, you can have what? These inhalational agent, any inhalational agent and succinylcholine. If someone is having ryanodine receptor mutation, what can happen in the patient? Patient can have activation of DHPR plus ryanodine receptor, leading to increase in the calcium, and this calcium will do what? This calcium will cause a disease that is known as malignant hyperthermia. This is known as malignant hyperthermia, and this is the malignant hyperthermia which is going to be the problematic thing, which is responsible for the raised AtCO2, double AtCO2, raised AtCO2 will be there, and this is going to be because of mutation in which gene? This is going to be your ryanodine receptor mutation, right? This malignant hyperthermia, drug of choice for this particular one is going to be IV sodium dantrolene. This is going to be the drug of choice. IV sodium dantrolene is the drug of choice here, right? Next one, we are having concentration of which of the following is maximally decreased in the PCT. PCT के अंदर सबसे ज़्यादा किसका concentration कम हो जाएगा? Concentration of which of the following will decrease in the PCT? This is going to be your glucose beta. Remember, glucose, 100% of glucose and amino acid will be absorbed where? In the PCT. In the PCT. In the PCT, 100% of glucose, 100% of amino acid will be absorbed, right? This is going to be afferent arteriole. This is going to be afferent arteriole. Here you will be having glomerulus, right? This glomerulus will be taking the blood away, right? This is the first part. This is proximal. This is convoluted. This is the structure of a nephron. First part is proximal, first part is convoluted. This is known as proximal convoluted tubule. Then we have got this loop of Henle. Then we have got this distal part. This is distal. This is again convoluted. This is known as distal convoluted tubule. And then we have got what? Then we have got collecting duct. These are your collecting ducts that we are having. And all these collecting ducts are going to drain the urine into the ureter. And from the ureter, this urine is going into the urinary bladder, and this bladder is going to take this urine out into the urinal. This is going to be the basic thing we are having in the urinal, right? Now, what are the drugs we are having? This PCT will be having action of the drugs like carbonic anhydrase inhibitors. Here in loop of Henle, you will be having sodium potassium 2 chloride pump, where Bartter syndrome can happen due to mutation. Bartter syndrome can happen, where you will be having working of drugs like furosemide. This is going to be DCT, where you will be having sodium chloride pump will be working, and the drug will be working are going to be your thiazides, right? Mutation of the sodium chloride channel is known as what? Gitelman syndrome. This is going to be your Gitelman syndrome we can have, right? And then we have got what? Then we have got this aldosterone. This aldosterone is going to work on the superior part of the collecting duct, and this aldosterone has a function to absorb sodium and water by making E-neck channel, epithelial sodium channel. And if there is mutation of this E-neck channel, this syndrome is known as Liddle syndrome, which is characterized by hypertension because of excess absorption of sodium and water. Excess sodium absorption will lead to obviously hypertension in the patient, because sodium, who will follow? Water will follow. Definite, simple understanding, right? And last part, lower part of the collecting duct will be having actions of antidiuretic hormone, which is working via V2 receptor, and this is going to have what? Aquaporins. And these aquaporins has got the function to absorb what? Water. This is going to absorb the water, right? If there is mutation of this aquaporins, if there is decrease in the aquaporins, you will be having what disease? Decrease in aquaporins, patient will be having decrease in ADH will be there, leading to what? Diabetes insipidus. This is going to be diabetes insipidus, right? If there is increase in ADH, this disease is known as SIADH, syndrome of inappropriate antidiuretic hormone, characterized by dilutional hyponatremia, right? Here you will be having polyuria, polydipsia, polyphagia, symptoms like diabetes. That is why we call it diabetes like insipidus, right? Drug of choice for central diabetes insipidus is going to be what? This is going to be desmopressin central. For nephrogenic, we have got thiazides. And here for SIADH, the drug of choice is going to be conivaptans. Vaptans are the drug of choice. Vasopressor antagonist are the drug of choice. Lastly, we have got RAS, renin angiotensin aldosterone system that we have got, right? This angiotensinogen is going to come from the liver. Let's try to understand. From the liver is going to make angiotensinogen, and kidney has got the function to convert angiotensinogen to angiotensin 1, right? With the help of which enzyme? This is going to be nothing but your renin. This is nothing but your renin, which is going to convert this angiotensinogen to angiotensin 1. Now this angiotensin 1 is going to convert into angiotensin 2 with the help of what? Angiotensin converting enzyme. And now this angiotensin 2 will be having two receptors. One is on the adrenal gland, another one is on the blood vessel. In blood vessel, it is going to do vasoconstriction, and this vasoconstriction will lead to what? Increase in the BP. Second receptor is going to be present on the, it is going to release what? Aldosterone. Second receptor is present on the adrenal gland, and it is going to release what? Aldosterone. And just now we have seen aldosterone is going to work on the upper part of the kidney, and it is going to make what? It is going to make ENaC channel, epithelial sodium channel, which is responsible for sodium and water retention. So sodium and water will be coming back to the body. More sodium, more water will be coming, leading to what? Leading to increase in the BP. So it is going to do sodium and water conservation, leading to what? Increase in the BP. So simple funda of this RAS system is to increase the BP, to increase the BP, right? We can block this RAS system to decrease the BP. By how? We can like complete BP you can understand with the help of ABCD, right? A for ACE inhibitor, A for ARB. We can use ACE inhibitor, we can use ARB. B for beta blockers, I have told you in the beginning itself. C for calcium channel blocker, and D for diuretics. And then we have nitric oxide releasers. These are nitric oxide releasers, right? They are also going to cause what? Vasodilatation, right? So these are the drugs for hypertension that we are having. This is the ABCD of hypertension. ACE inhibitor are going to work where? You can block this renin directly. First of all, you can block the beta system. You can give the beta blocker, so there will be no renin. If there will be no renin, there will be no problems, right? Second thing, you can do what? You can give ACE inhibitor, angiotensin converting enzyme inhibitor. These are the pril group of drugs, captopril, lisinopril. Third thing, you can give angiotensin receptor blockers. These are going to be your sartans. Tell me sartan, low sartan, valsartan, right? These are the group of drugs. Then you can give aldosterone antagonist. This is going to be your spironolactone. This is going to block the aldosterone. These are the drugs you can utilize over here, right? Basic class of the drugs, right? I told you calcium is responsible for vasoconstriction. You can block this with the help of drugs like amlodipine. Diuretics, we have discussed all the diuretics, right? Next question. Next question is pacemaker controlling the rate of respiration. Last question we have got. Pacemaker controlling the rate of respiration, which is going to be the pacemaker for respiratory system. Pacemaker for GIT is going to be what? Pacemaker for GIT is interstitial cells of Cahl. Cells of Cahl. Right? Pacemaker for respiratory system is going to be your pre-Botzinger complex, beta. Pre-Botzinger complex. So let's try to understand how we are breathing, right? Just try to understand. This is going to be, you have completed your anatomy also, right? This is going to be your corpus callosum. Below the corpus callosum will be somewhere you will be having thalamus, and then you will be having hypothalamus, and below hypothalamus you will be having this gland. This is your pituitary gland. This is your cerebellum. This is going to be your midbrain, pons and medulla. This is going to be midbrain, pons and medulla, right? Here somewhat you will be having this fourth ventricle, right? So I'm just opening this particular part out. This is the midbrain, this is the pons, this is the medulla that we are having, right? So we have got our respiratory center in the pons and in the medulla itself. 5 nucleus होंगे, 5 nucleus you need to remember. What are those 5 nucleus? First one is going to be pneumotaxic center. You must have heard about some snake venoms. This is your pneumotaxic center that we are having. Second one we have got is apneustic center, which is the first center to get activated when a baby is born. Inside the womb only one organ is not working, that is the lungs. So once the baby is coming out, the apneustic center is going to come into action, right? This is going to be apneustic center. What is this above center? This is your ventral one. This is coming on the front side. This is your ventral respiratory group. This is on the dorsal side. This is known as dorsal respiratory group, है ना? इनका एक एक फंक्शन अपन को पता होना चाहिए. At least one function you should be knowing, right? I'll just give you the mnemonic. What is the mnemonic? This is the mnemonic DIE. Dorsal respiratory group is responsible for inspiration, whereas ventral respiratory group is responsible for expiration. Dorsal किसके काम में आता है? Dorsal is responsible for inspiration, ventral is responsible for expiration, right? What about this pneumotaxic center and apneustic center? Pneumotaxic center और apneustic center क्या काम में आते हैं? Just try to understand this. We have got pre-Botzinger complex. Pre-Botzinger complex का क्या function है? It is the pacemaker. इसका फंक्शन होता है कंट्रोल करना रेस्पिरेटरी रेट को, राइट? नॉर्मल रेस्पिरेशन ज्यादा हो रहा है, तेज हो रहा है, उसको कंट्रोल करना किसका फंक्शन है? दिस इज गोइंग टू बी प्री बॉट्जिंगर कॉम्प्लेक्स. न्यूमोटैक्सिक सेंटर इज गोइंग टू लिमिट द इंस्पिरेशन. आप ज्यादा इंस्पायर ना कर लो, उसको लिमिट कौन करेगा? न्यूमोटैक्सिक. एक बार पढ़ लो, अब मैं समझाता हूँ, राइट? एपन्यूस्टिक सेंटर इज द सेंटर विच इज गोइंग टू प्रोलॉन्ग द इंस्पिरेशन. इसीलिए तो दिस इज द फर्स्ट सेंटर टू गेट एक्टिवेटेड, है ना? जैसे ही बच्चा बाहर आएगा, एपन्यूस्टिक सेंटर विल गेट एक्टिवेटेड, यू विल बी हैविंग प्रोलॉन्गेशन ऑफ इंस्पिरेशन, ताकि बच्चा बाहर आके सांस ले सके. Dorsal respiratory group is responsible for inspiration, whereas ventral respiratory group is responsible for expiration. DIE. So let's try to understand this, how this thing is happening, right? How this thing is happening. This is your respiratory center present in the brain, right? Now just try to open this. First, pneumotaxic center and apneustic center are going to be there. So let's begin with the inspiration, how you are inspiring. Let me make you understand. Your apneustic center is the first center to get activated. apneustic center activate होगा, किसको activate करेगा? dorsal या ventral respiratory group को. It is going to activate. For inspiration we require what? Dorsal respiratory group. Dorsal respiratory group will be activated for inspiration, right? And inspiration, expiration, all these things are dependent on simple formula. This is going to be pressure is inversely proportional to volume. आप प्रेशर बढ़ाओगे तो वॉल्यूम कम हो जाएगा, वॉल्यूम बढ़ाओगे तो प्रेशर, वॉल्यूम बढ़ा दोगे तो प्रेशर कम हो जाएगा. सेम स्टोरी, राइट? If there will be increase in pressure, there will be decrease in volume. If there is decrease in the pressure, there will be increase in the volume. Simple funda, right? So how you are going to breathe, this is the thing you need to understand. 75% of the breathing is happening because of the diaphragm. So whenever, just try to understand, whenever this dorsal respiratory group is activated, ये दो मसल को activate करेगा. For inspiration, 75% of inspiration is because of diaphragm and 25% of inspiration is because of external intercostal muscle. Just try to understand this. When you are inspiring, your diaphragm will be going below. Diaphragm will be going below. That means pressure will be low. If the pressure will be low, what is going to happen? The air will come inside. Pressure कम हो जाएगा तो क्या वॉल्यूम बढ़ेगा? Yes, प्रेशर कम हो जाएगा तो वॉल्यूम बढ़ेगा. और आपके जो एक्सटर्नल इंटरकोस्टल मसल्स है ये दूर दूर जाएंगे. दीज आर गोइंग टू गेट अवे, राइट? तो दूर जाने की वजह से यहाँ पर भी प्रेशर क्या होगा? प्रेशर कम हो जाएगा. इफ देयर विल बी डिक्रीज इन द प्रेशर, दिस मसल्स आर गोइंग अवे, दिस मसल्स आर गोइंग अवे, दिस मसल इज गोइंग अवे, डायफ्राम इज गोइंग अवे. व्हाट इज गोइंग टू हैपन? यू विल बी हैविंग इनहेलेशन, you will be having inspiration. So this is the basic funda for inspiration. 75% of the inspiration is because of diaphragm, 25% is because of the external intercostal muscles. ठीक है? उसके बाद में क्या होगा? After inspiration, this DRG is going to activate your VRG. This is going to activate your VRG, and this VRG is going to activate two things: accessory respiratory muscles and internal intercostal muscles. These are the two muscles which are going to get activated. अब ये दोनों क्या करेंगी? ये दोनों कंप्रेस करेगी. अगर ये कंप्रेस करेगी तो प्रेशर बढ़ेगा. अगर प्रेशर बढ़ेगा तो वॉल्यूम क्या हो जाएगा बेटा? वॉल्यूम कम हो जाएगा. अगर प्रेशर बढ़ेगा तो सो दीज आर द मसल्स विच आर गोइंग टू कॉन्ट्रैक्ट एंड लीडिंग टू व्हाट? इंक्रीज इन द प्रेशर. और ये अंदर की तरह कंप्रेस करेगी, जिसकी वजह से क्या होगा? वॉल्यूम कम हो जाएगा. वॉल्यूम विल बी डिक्रीज एंड प्रेशर विल बी इंक्रीज. दिस इज हाउ वी आर हैविंग व्हाट? एक्सपिरेशन. एक्सपिरेशन के लिए कौन सी मसल काम में आती है? वेंट्रल रेस्पिरेटरी. कौन से न्यूरॉन्स विल बी एक्टिवेटेड? कौन सा सेंटर विल बी एक्टिवेटेड? दिस इज गोइंग टू बी वेंट्रल रेस्पिरेटरी ग्रुप. इसका फंक्शन क्या होता है? एक्सपिरेशन. राइट. दिस इज रेस्पॉन्सिबल न्यूमोटैक्सिक टू लिमिट द इंस्पिरेशन. ये ब्रेक की तरह काम करते हैं. नॉर्मली इट इज गोइंग टू लिमिट द इंस्पिरेशन. ऐसा नहीं बहुत ज्यादा ऑक्सीजन ले ले तो उसको लिए ये चेक पॉइंट बैठा हुआ है. दैट इज द न्यूमोटैक्सिक सेंटर वी आर हैविंग. राइट. So with this thing, I think we are done with this particular session of important topics that can be asked in your examination. Remember, beta, nobody can go back and start a new beginning, but anyone can start today and make a new ending, right? Tell yourself each and every time the most important thing that you can do with yourself is to believe in yourself, right? This is the most important thing that you can do to yourself. Okay? तो believe करो खुद के अंदर. ऑब्वियसली एग्जाम तो कुछ भी नहीं है. एग्जाम बहुत छोटू सा एग्जाम है. इट इज जस्ट लाइक ए स्मॉल पेबल, है ना, छोटा सा पत्थर है. इसको पहाड़ नहीं बनाना. पहाड़ बना के चलोगे तो और बड़ा लगेगा. राइट. जैसे छोटा सा पत्थर समझोगे तो इट विल बी वेरी वेरी इजी फॉर यू. राइट. These are my Instagram and Telegram. In case if you are finding any difficulties, always feel free to reach out to me. I would be more than happy to help you out. No issues with that, है ना. But make sure you keep on learning things, keep on revising things, and you will definitely pass. I would like to welcome you, all of you, on the other side of the fence very soon. Right. Thank you so much for all the patience. We'll be meeting tomorrow for the new session that is going to be anesthesiology. We'll be discussing that. Okay.